When do you know? Just like you say, okay, go down to
their bosses, and if they are cute, let's get to that. Sports now. This one girl in sports now. Look at it. Number one. This one girl in sports. No, as I'm going to go bigger age now, and there are a lot of coaches like I'm seeing right now. This is 531. This is 531. Look at the bosses. There are lots of bosses. Look at a lot of bosses. Bosses. Nobody on the queue. Look at bosses. There are a lot of bosses and there are nobody on the queue. We go to the other animals go pass. There is this part. There is one of
no, the Indian doctor Kena. Mercedes, I did join number living or Kanya, no Kanya, and here, Kenya, Fogi, and Naba. I Mercedes, I did join on ya, Hassan or Norian, and you did. I am
All right. Good evening, everyone. Thank you so much for joining us today. It's really great, wonderful. I can see a lot of excitement, a lot of enthusiasm. Many people have signed up for this workshop, and I want to sincerely thank Mr. Olagote Serafin. He's one wonderful person that I've come to know recently. We all know that one of the most important things ahead of us that is sure going to expand our practice and give us that recognition that we have all been yearning for, is the issue of training. And training at a specialized level. And to do that, I think we need to all work together, those within the country and those outside the country, everyone that has any experience that can help us to upgrade our practice is really always welcome to be with us in this, support us with these trainings. I had a discussion with our resource person today, realized that he has a lot to offer to us, and we invited him to support us with trainings. And he obliged us. And one very good thing was when we asked what the fee for the training should be, he said he was going to offer free. And we really appreciate him. And that is why there is no fee to the workshop, apart from the little amount that was asked for the purpose of processing the certificate. So I want to thank our resource person. May God bless you. And we want to ask that you also reach out to other colleagues in the diaspora. Let's have more people that are going to give back to Nigeria and also support us to be able to continue on this part of training, upgrade of our practice. Thank you so much. May God bless you. I'm going to hand over to you because we already have 13 minutes gone already. Thank you so much. Over to you.
Hello. Hi, can you hear me, please?
Yes, we can hear you.
All right. I'm just all right. Good day, everyone, and thank you for joining, and thank you for having me on the call today. First of all, I would like to appreciate the board, the MRTB, and particularly our registrar for getting me on board to be able to deliver this training for us. Thank you very much, sir. I really appreciate the effort, and I really appreciate you bringing me on board. And thank you everyone for joining in. It's good to speak to you guys. Over the couple of weeks, just like the registrar have mentioned, we're going to have trainings focusing on acute care physio essentials, and just give me a sec. Yeah. So we're going to have trainings focusing on acute care physio essentials. So my name is Sheriff-Din Olagoke, and I currently practice in United Kingdom here in Coventry Hospital here. So today we're going to talk about blood tests for physios, and so please, can you guys see my slide, please?
We can see a slide,
Yes,
but it's not on a presentation mode.
Yeah. How about this? Is it more very feasible?
Well, it's okay. It's not still not on presentation mode, but I think it's okay. We can see it.
Okay. All right. So let me just crack on. All right, so like I mentioned, so we'll be having discussion today on blood tests for physios. And so I'll be taking us through full blood counts. I'll talk about urea and electrolytes. So I'm going to talk about inflammatory markers. I'm going to talk about kidney function test, liver function test. We're going to have some few case studies to go through together. And if we have the time, we'll also touch on ABGs as well. So all of these discussions, we're going to relate everything down to physios, why we need to know all of these things, what we need to be doing for our patient, and if our patient are acutely deteriorating, how do we identify them and how do we escalate? So this is why we need to know all of these things, and these are stuff we'll be talking about today. So why is this study or why is this training very relevant to us as a physios? The first thing I'm going to talk about here is just to facilitate patient care. And like we all know, everything we're doing currently in acute settings is all about patient care, optimizing patient care. And again, so blood counts represent, or blood, knowledge of blood actually represent the minimum standard that we need to know in acute settings as a physios, because knowing blood tests can help you to identify, better understand patients' medical conditions. It can also help you to understand their resilience. If you need to do your stuff with them, if you need to do exercises with them, if you need to, if you need to do you can also, with your knowledge of blood tests, you can also use that to track down your patient if they're actually progressing well, or if they are actually regressing, or if they are not progressing with you can actually look into your blood test and make your analysis. Okay, wow, this is why my patient are not actually, this is why my patient are actually struggling in my rehab, and this is what I've got to modify. This is what I've got to do better. So it's just, so the knowledge of blood tests can also enhance our patient care as well. And also when it comes to MDT, our knowledge of blood tests is also very, very crucial when it comes to MDT, because I used to tell guys that I think one of the ways we can be more respected in Nigeria generally, I used to tell people, is getting to know some of these basic things. Yeah, because with blood test, you can actually know some medical stuff about patients. You can actually know, okay, I can easily look at the blood, for example, now and say, oh, this is why this patient is very poorly on bed, because their infection marker is highly going up. I can easily go meet a medical doctor and say, oh, I sent to him, what are you guys doing about this patient that has been poorly on bed? What antibiotics are you guys looking at getting patient on? And again, when it comes to my treatment as well, I can actually relate my own treatment. We've been trying to do this, but they are currently not, they've got reduced exercise tolerance. They've got reduced, their chest is actually deteriorating, possibly because of their infection markers that is shooting up, or all of those things. So it will further enhance our MDT workings by some basic things about blood. And aside from that, when it comes to treating patients as well, your knowledge of blood can tell you, do I need to treat them? Do I need to leave them? Or what time of the day do I actually need to treat my patient? Because there are some patients, for example, now, if you're on renal ward, for example, now, with your knowledge of blood, you will need to make some decisions like, do I need to see my patient before dialysis, for example? Do I need to see them during their dialysis, or have they got to be seen after their dialysis? Or you've got a patient on the ward, they are very, very confused, and we all know what confusion means to our patient and what it means to us as a physio. And I actually need to look at their blood as well and say, okay, yeah, it could be maybe in some time of the day, maybe in the morning or in the late evenings. These are when they normally get very, very orientated, very calm, and looking well settled. You might actually think about targeting your rehab to those period of time. So knowing blood tests will give us some of these clinical reasonings to make some excellent decisions for our patients. And again, we cannot rule out the impact of blood tests when it comes to making patient diagnosis. So it's also very important as well. So let's get at this thing. So the first thing I'm going to talk about here is blood generally. From our background in biology or physiology, everyone knows when we talk about blood, generally, we've got blood cells. And when we talk about blood cells, these are red blood cells, the white blood cells, the platelets, These are the solid component of blood. And also you've got the plasma, which represent the liquid component of blood. So I'm not going to touch on the rudiment knowledge on none of these things, of course. So the rudimentary knowledge are not very important to us as a physicists, but just remember blood cells, white blood cell, red blood cell, platelet, and we've got plasma. So let's move forward. So when we talk about blood cells generally, full blood count, these are terminologies everyone have heard before. We've heard people talking about blood counts. So what does it mean when we hear blood count? So blood count just means, you are talking of your red blood cells, you are talking of your white blood cells, you are talking of your blood platelets. That's what blood count, full blood count means. And where are these blood? Where are them being produced? These are blood that are made predominantly in the bone marrow. I know in infants, in peds, it can be made elsewhere, maybe in the liver or something, but that is beyond the scope of this discussion here. So anytime we hear people talking about hematology, just stick in your head. What does that mean? Full blood count, FBC. Talking about red blood cells, they want to look into red blood cells, they want to look into their white blood cells, and they want to look into their blood platelets. Are we still here, please? Can you guys still hear me?
Yes, we can hear you.
Perfect. All right. Thank you, sir. So let's move forward. So let's talk briefly about red blood cells. Like I mentioned, we're not going to touch into the rudiment knowledge of it, but we just link it back to physics and what we need to know. Again, red blood cell, we know these are numerous cells. We've got plenty of them in our bodies, and what they do is they all carry oxygen around in our body. Everyone knows all of these things. And then, of course, they've got values as well, because in males, you can have the values as high as this that is written on the slide. In female, we can have the value as high as this, as it is written on the slide as well. But do we really need to cram or remember this value? The answer is no. It's not relevant to you as a physicist. You don't have to cram the values. And again, why don't we have to cram the values? Because for every blood cells or for every blood result, they will always come with a reference range. Do not commit this to your brain. It's useless. Just leave it. Now, what do you have to remember here in this slide, in this particular slide? So you've got to remember that on your red blood cells, you've got a lot of indices, a lot of stuff that are making up of your that are made up of your red blood cells. These are stuff you actually need to remember here. They've got plenty of them, but three are very, very important to us as a physicist. Your HB, very, very crucial. You need to know some stuff around your HB. Your PCV, very crucial to you as a physicist. You need to know stuff around your PCV. MCV is also important, but yeah, in some aspect, very important, but remember some certain stuff about that. So I'm going to talk about this now. Let's discuss. So now let's talk about hemoglobins. So when we say hemoglobins, globins are proteins. They are generally proteins. They are proteins on red blood cells. And what do they do generally? They carry oxygen around in the body. So now, normal values for hemoglobin, you've got the value again on the screen. From males, the value is there. For female, the value is there. Do not cram this. It's useless. You don't need to cram it, because every blood, again, like I said, every blood will come with a reference range. Now, look at the unit here. I put gram per liter here. Depending on where you work, depending on your settings, depending on the lab values that deem obtainable where you work, sometimes you can have, there could be different categorizations. Sometimes you can have categorizations like maybe gram per deciliter, something like that. So let's say, for example, now I want to turn this to deciliter. So what that means is I just have to divide this by 10. So that would be 12 to 15, that would be 13 to 80 in case of male, yeah. But actually, do not commit this to brain. It is very, very useless, because all blood tests will come with a reference range. But what do you have to remember? Low HB, physios, you need to remember that's anemia. Now, what are the conditions that can make a patient to have low HB? HB is very, very important. Low HB, you need to be aware of it. Now, the first thing is blood loss. Let's talk about blood loss. Imagine you've got a patient on the ward, let's say on ENT wards or head and neck ward now. They've had the recent surgeries in their neck. Let's say they've got neck dissections, they've got tracheostomies, they've got laryngectomies, or they've got maybe upper abdominal, esophageal surgeries as well. So these are big surgeries. It could be patients that have had a traumatic brain injuries, or they've had a TBI, or maybe they've had a major surgeries to their limb, maybe vascular surgeries like below-knee amputations or above-knee amputations, or maybe maybe you work on gastro wards, maybe you've got a patient now that have had surgeries to their abdomen, maybe laparotomy, Whipple surgeries, any surgeries. Think of any surgeries. These are big surgeries, and these are our patient group that we need to be seeing. We need to in this kind of patient categories, they might have lost a lot of blood. Generally, before I go in to see them as a physio, you need to look into their blood. You need to check their hemoglobin. That is very, very key for you. Because if you go in, let's say day one post-op now, you go in to do your stuff with them, to get them up, get them moving, or maybe you've been called to see them for chest. Because these are big surgeries. Some of them can come out of surgeries, and they can develop a post-pulmonary complications. So you can be called to come see this kind of patient. So you need to be checking their HB, because put in your clinical reasonings, that post-surgeries, they might have lost some significant blood. So now, that is one. You might also have a patient on the ward, they are not eating well, they are not drinking well, they are very dehydrated, their HB can also be impacted, their HB can also be low. Now, and aside from that, some other things that I didn't tell you initially was about red blood cells, also contain folate, iron, and vitamin B12. So if a patient is deficient in any of these things, all of these things can also make a patient have a low anemia as well. The patient, let's say they are being malnourished now, or maybe they've got some reabsorption issues, maybe in their colon, for example. If you're on gastro ward, you might be presented with some of the patients that have issues with the reabsorption in their intestines. Some of them might have Whipple surgery, for example, some part of their intestine being removed. These are our patient group that we need to be seeing them as well. So now, so if you have this kind of patient, let me just give one clinical reasoning here. Let's say, for example, what they normally do. Let's say you've got a patient now, they've been admitted to your unit, they've got a low HB, and some other things you can do is the medics will go up, they'll go check their MCV. So what MCV does is it determines the size of your blood. That's what it does. Now, if a patient is coming to the hospital with low HB and the MCV is very small, is low as well, let's say less than 80 now, for example. So that could be indicating something. It could mean that maybe your patient is bleeding somewhere. Maybe they are losing blood gradually somewhere. I give you a good example. Imagine a patient that had a fall, and let's say now in their upper tummy, they've got bruises in their upper tummy. And I've been asked to go see this patient. And when I check in their lab result, when I check in, I see that their HB is very low. And aside from that, I also look into their MCV, and I see their MCV is very low. In my head, I'm going to make a clinical reasoning that this patient is likely to be bleeding in their upper GI. They are likely to be bleeding in their upper tummy. So all these kind of things, as a physio, we need to have an awareness of them. And aside from that, but if you really want to be really sure that it is an upper GI bleeding, you can also check their urea. I'm going to talk about that in a jiffy. So in all of these things I've been saying, what do you really have to remember? Remember that low HB is very relevant to you as a physio. The patient with big surgeries, you need to check their HB. A patient that is very dehydrated on the bed, you also need to be checking their HB as well. So, and again, high HB, polycythemia, a lot of reasons can make a patient to have polycythemia as well. I give you a good example. Like in the case of, let's say, a patient that have come into the hospital, they've got chronic, let's say chronic COPD patient or a chronic smoker now, for example. We know what happened in the COPD patient. They tend to have a barrel chest. So because of the barrel chest, they normally struggle to empty their chest because of a big chest. They've got respiratory issues to empty their chest. In this patient, normally, they are prone to, they've got reduced oxygen in their body. So the information that will go back from the brain to the kidney is we need to make a lot of blood cells because the oxygen in the body is low. In that regard, you could have some chronic COPD patients, their kidney will produce a lot of erythropoietin cells and they start making blood. They start making blood, start making blood cells. So what do you have to remember again? Let me repeat here. So the normal value, it is useless. You don't have to cram it. You don't have to remember it because every blood comes with a reference range. And aside from that, low HB, you need to be aware as a physios. And a lot of reasons can also actually make a blood to be low as well. Let's crack on. All right. PCV, let's talk about PCV. Now, why I'm talking about PCV here is I know most of our settings in Nigeria, what we use, the parameter we use is PCV. And PCV generally, it means hematocrit. And it's just, what that means is just the percentage of blood that contains red blood cells. If you look at the picture here, it means the percentage of red blood cells in all of these things. You may not remember that. What do you have to remember? Just remember PCV is expressed in percentage. And sometimes you can also find this as a ratio as well. You can find this as a ratio. But usually in most hospitals, you'll find this in percentage. If this is the designation that is being used in the hospital, usually you'll find this in form of a percentage. Low PCV as well is going to be anemia, high PCV, polycythemia as well. So, and again, approximately, if you multiply hemoglobin values by 3, you can actually use that to estimate your PCV value as well. We just need to make an awareness of that as well. So HB or PCV, which is more accurate? Let's talk briefly about that. Which do we think is more accurate here? Yeah. So generally speaking, HB is more prevariable and much more accurate than PCV. Reason being that the fact that, don't forget what PCV is just saying. It's just saying the red blood cell, the total red blood cell that you've got in your blood. That's what PCV is just saying. The percentage of red blood cell in your blood. But HB, the fact that you've got plenty red blood cells does not actually mean you might actually have that plenty HB in your blood as well. It might not necessarily mean, especially especially if you've got a patient that are sickle cell patient. In sickle cell patients, I'm going to prefer checking HB if that is available than having to be looking at their PCV. And again, in a chronic anemia patient, their HB is usually very low. That's their baseline. I might be needing to be, checking their HB as opposed to PCV. You might find patients like maybe a CKD patient, a chronic kidney disease patient. You might find them in this category. So, and again, you also need to be careful with PCV if you are also working with a patient with acute blood loss. Let's say they've done big surgeries now. They've done esophagectomy now, surgery involving the esophagus and the stomach, for example. This is a very big surgery. Or somebody with trachees in their neck, or laryngectomy in their neck, or somebody that have done above knee amputation. These are big surgeries. The chances there that they might have lost a lot of blood. So I would rather prefer to look at HB as opposed to PCV. And some other things that let me just go back to that slide that I also need to talk about here is PCV can also be, for example, now if you are very, very dehydrated, your PCV is going to be really, really very high. So if you are very hydrated, let's say you've got a patient on the bed now, they are not drinking, not eating well, and let's say they have been giving fluid. Now, if you tend to give them a lot of fluid, that is going to dilute their blood. And what will happen is their PCV is going to drop as well. So all of these things are these are further stuff that are not making PCV to be really, really very accurate as we want them to be. So just be aware of this. But if PCV is what is being obtainable or what is available in your hospitals, of course, you can still go with it, but just be careful. Have that clinical reasoning in your head that, oh yeah, this is just like a rough estimate. Is not actually telling you the amount of HB or the amount of oxygen that is being carried to the cell. So you need to have that background and you need to have that clinical reasoning in your head. All right. Sorry, guys, am I making sense, please?
Yes, sir.
All right. Thank you for that. So let's move forward. So what really matters to you as a physios? I have talked about HB. I have talked about PCV. If you don't remember anything I've said, remember low HB is a concern to you as a physios. Low HB. So why is low HB a big concern to you as a physios? Because HB carry oxygen around in your body. If somebody has got low HB, they are prone to physiological reactions. They can collapse, they can die, they can be very, very fatigued, they can have reduced exercise tolerance. So they can be very, very poorly. They can be really, really very short of breath. That is why low HB is really a big concern to you as a physician. Now, in terms of reference range, when do we do stuff with our patient? When do we need to be very cautious, or when do we need to be very careful working with our patient? Yeah, let's get at this. So now the first thing I'm going to talk about here, if HB generally is less than 70, if your designation is gram per deciliter, that will be less than 7, likely that your patient might be awaiting blood transfusions. If the HB is less than 70 or less than 7, they might likely be awaiting blood transfusion. You need to remember this as a physio. This is very, very important to you, because you don't want to go in, start thinking you want to get up somebody that HB is very low, and maybe now they are waiting blood transfusions. You are putting the patient at high risk of fall. You are putting the patient at high risk of collapse. So you need to be really careful there. So now that does not still mean if HB is less than 70, I can still do stuff with them. But you need to look at the medical notes, you need to look at the medical plan, you need to speak with the consultant in charge. And again, even if you really have to do something with them, you need to weigh in your risk and benefit. And these are decisions we want our senior physios to be making on the ward. These are not decisions with our junior, these are not decisions that can be championed by our junior physios, by interns, by early career physios, or by Part 5 students. No, we don't want that. We want all of these risks, when risk and benefit decisions, to be made by a senior physio on the ward. So we need to be aware of that. So generally, if there is one value I'm going to tell you, I'm going to say, generally, if HB is less than 80, junior physios, don't do it, leave them, no rehab, leave them in bed. Senior physios, if HB is less than 80, yeah, you can think about it, risk versus benefit. Think about it. If I don't do my stuff, yeah, what is going to happen to my patient? Yeah, what is the medical plan? What have they documented? Is this patient currently awaiting blood transfusion? What your benefit? Even if they are awaiting blood transfusions, if, let's say, for example, now you've got a patient on the bed, very, very poorly on the bed, they are awaiting blood transfusions, they've got really, really bad chest infections, they are sounding cracky, they are whistling. And so this kind of patient, and if you don't do your physio stuff with them, they are likely to pass away. So you might need to weigh your risk and benefit. And these are decisions, again, that needs to be done by senior physios. All right. So now, generally, if HB is less than 80, I would say keep them in bed. But if you've got good reason to see them, yeah, you can crack on to see them. But there are exceptions to that. If you've got a renal patient, for example, renal patient that are being dialyzed, they are on dialysis, because patients on dialysis, their blood are being filtered, their HB can get really, really very low. Yeah, HB of 80, yeah, I will do less than 80, I will do my stuff with them. 75, I will do my stuff with them. 74, I will do my stuff with them, no concern. And if you've got a patient with, let's say, sickle cell anemia, they've got a really, really low HB level, their baseline is really, really very low. But if you are not very confident to crack on to do your stuff, what you can do is speak with the medical team in charge, understand their baseline, what is their baseline of HB, and you can also get these people to document. We're going to talk about documentation in our next sessions. I'm going to talk about why these are legal stuff, and why we need to be taking those things really, really very serious. Anyways, let's move forward. So remember, HB less than 80, don't do stuff with them, except if they are renal patient, or if they've got they are chronic anemic patients, like in the case of sickle cell anemia. So, and again, for a cardiac patient, let's say you've got a patient, you are on coronary ward now, you are in cardiac ward, you've got a patient with, let's say they've got TAFI, they've done a recent surgery like TAFI, or they've got open heart surgeries, or they've got, it could even be a coronary heart disease patient, or they've got heart failure, for example, now. So I would normally advise that you keep their HB as high as possible. Keep it more than 90. Because the reason being that they've got heart issues, if their HB is really, really very low, and again, some of them might even be struggling with ventricular issues, their ventricle might be struggling to pump blood to their general circulations. So if you keep HB very low, their brain might be hypoperfused, their kidney can be hypoperfused. So I'm going to say, if you've got a cardiac patient, keep their HB as high as possible. All right. So I'm going to ask us a question here before we move forward. I don't know if we can get people to speak. So if we are making an assumptions, of course, these are reference range that are actually needed to be put in the context of our patient. Actually, there is no general rule, but it's just like a rough estimate to guide us, to guide our workings on the ward. So if we can get, so I'm going to ask a question here, and the question is going to be, if we are making a rough estimate that age be less than 80, we want to be cautious, caution to be doing stuff with our patient. So what do we think? Suppose in my hospital now, we use PCV. So what do we think is going to be a rough estimate? And people put in the answers in the chat box, or if you have to speak, you can raise your hand, you can be called upon to speak. Yeah. What do we think, guys? Can we get reaction, please?
Yes, we can divide it by 3. You said the approximate value is 3 times the PCV is normally 3 times the HP.
Yeah. Perfect. Thank you. That's okay. If I leave that. So what do we now think is going to be like a reference range for PCV now, for example? What do we think? If I've got a cardiac patient on the ward and I've got PCV in front of me to work with, and this is a patient, cardiac patient, recent cardiac patient, let's say coronary artery heart failure patient, they've just got approved knee amputations, and I've got PCV in front of me. So what do we think? What PCV are we actually looking at? Yeah, Mr. Success. Can we actually get people to speak up, or just pop the hand?
Can I speak?
Yeah, go ahead.
Okay. That's, we should be targeting about 27 and above.
Yeah, perfect. Yeah. How about if 27 and above, is it for a cardiac patient or non-cardiac patient?
That's for a cardiac patients.
Yeah,
and
great.
non-cardiac. And those with above knee amputation.
Yeah. Cool. Perfect. So it's just a rough estimate. So for PCV as well, for PCV, I'm going to say if your PCV is less than 21, roughly less than 70 for if you are using HB, please leave them. Don't do stuff with them. It's very dangerous. If you need to do stuff, you need to weigh your risk and benefit, and that decision needs to be made by senior physios on the ward. And the senior physio as well, you might also consider speaking with the consultant in charge before you go ahead to see your patient. All right. And again, if PCV is greater than 24 for non-cardiac patients, do your stuff with them. Yeah, no concern. Get them up. Put it in. You can only be concerned. Put it in the context of the patient. If they've got other things going on in their body, yeah, you may then need to look into it. For example, now other blood values might be raised, something like that. But for PCV, we are talking here. If greater than 24, I'm fine. I'll get them up. If I'm being called to see for them for chest, I'll do my stuff with them. That's fine. But for cardiac patients, I want to keep, just like she mentions, greater than 27, greater than 30, as much as possible for cardiac patients, because I know the impact that dropped in PCV might mean their brain might be hyperperfused. Their kidney might be hyperperfused. Their liver can also be hyperperfused. So put all of these things in the context of your patient. Hope that makes sense. Let's crack on. All right. All right. So for chest patient here, because in acute settings, your skill set in managing chest, it really needs to be very, very good, honestly. So we need to talk briefly about chest as well. So for chest, let's say you are being called upon to see a patient, their PCV is really very low, and these are patients that you've got evidence of secretion retentions, lung collapse, they are really dying, they are desaturating, and they are currently awaiting blood. What do we think? And you are being called to see them. Honestly speaking, I'm going to say their low HB or low PCV in that regard is not an absolute contraindication to them, but it's relative contraindications. But again, in that regard, I would say junior physios, speak with seniors. What do we think? This is a poorly patient on bed. They are waiting blood transfusions. They are dying in bed. And I know if I don't intervene, my patient might likely to die of respiratory failures. So now, what do I need to do in this regard? I need to weigh the risk and benefit as well. If I don't see them, what is going to happen? If I see them, what is going to happen? So if I see them after their blood transfusion, what is going to happen? If I see them before blood transfusion, what is going to happen? So you need to weigh those risks and benefits. And if you really need to see them as well, clinical reasonings, they've got low HB. Any of your techniques you've got to do with this patient is likely to fatigue this patient. Don't forget, they are already, even with low HB, you know already that they've got good reserve at the moment, good physiological resilience at the moment. They are likely to fatigue very easy. And even some of them might even be very poorly in bed. They can be very fatigued, physically fatigued in bed. Now you are going to need to do manual stuff, to do percussion, shaking and stuff. You are going to need to do suction. I know we don't do suction in Nigeria. This is one of our stolen skills. We need to be doing it, yeah. So we need to, positive pressure. I might be going to think about, oh, now this patient is really poorly. I need to augment their cough. I need to bring in my cough assist. I know this is one of those things, again, we are not doing in Nigeria, but we need to start talking about those things here to support our patient. Now, if I really need to use any of these skills here to support my patient, if I really have to use any of those skills to support my patient, that poorly patient in bed, I need to ensure those things are graded. If I need to use positive pressure, for example, now, because I know when I use positive pressure, their interthoracic pressure will get rise. When that gets rise, their cardiac output will drop, their venous return will drop, their blood pressure will drop. And these are people that have low blood already. So I need to ensure those things are well graded. If I do suction, for example, now, suction already, even if they are fit and healthy, if I do suction for a patient, sometimes some people might get lung de-recruitment. Now you are now having a poorly patient in bed. So if you do suction, you know that can further make them to fatigue more. So you need to ensure, or if, let's say manual techniques now, I need to do percussion now for somebody that is visibly fatigued in bed, and I want to start doing percussions, or I want to do abdominal mark with them. So all of these things can further make them fatigue. So I need to ensure whatever things I need to be doing with my patient needs to be graded. And again, these are decisions that needs to be taken by senior physios, not interns, not early career, not part 5 students, because they might struggle to assess their fatigue level. And again, before I close this chapter on HB, if your patient is on blood transfusions, let's say you've gone to see a patient on the ward, they're on blood transfusion at the moment, don't get them out of bed. It's dangerous. Don't mobilize them out of bed. But if you need to do, if you really want to do some stuff with them, you want that carryover of your Urea, just do bed exercises, make it light bed exercises, late leg raise, this, eat light, leave them in bed. After blood transfusion, back on with your Urea, that's fine. But for that moment, leave them in bed, don't mobilize them out of bed. All right, that's that. So real case discussion here. So we're going to have to discuss here. So this is a hypothetical example. You've got a 65-year-old lady. She's been admitted for a CAP. CAP is a chest infection. That's community-acquired pneumonia. So she's got a CKD, stage 4. She's got iron deficiency anemia. So with a very poor heart, she's got heart failure as a background as well. The ejection fraction is 40. That's a poor heart. So this lady have got CKD. She's got a poor heart. Now she's having a chest infections, and the HB is 76. So guys, what do you think? Will you be treating them? Let's get reaction, please. Let's get people to speak up. Will you be treating them? What do you think? Reactions. This is a patient here. They've got CAP, chest infections. Yeah? So will you be treating them? Let's get reactions. Yeah? Hello, can you hear me, please?
Yes, you can hear you.
Yeah. So let's get reactions.
Because the hemoglobin level is low, is below 90 grams per liter, I won't treat such a patient.
Okay. So why will you not be treating them?
Because of the low hemoglobin level.
Okay.
Excuse me, can I also speak?
Yeah, speak up.
Okay. I also will not treat because the patient is a known cardiac patient.
Okay.
So yes, and her HB is 7.4, so it's very low. So I need HB from 10 or 9 and above for me to be able to do anything for her. So I won't do anything for her.
Okay. Well, this is a poorly lady on bed now. She's got chest infections, she's sounding cracky, she's whistling and stuff.
Okay.
Yeah. Let's get reactions. Yeah. Yeah. Please let's speak up.
Can I say something?
Yeah. Yes, ma'am. Yeah.
Okay.
Go ahead.
All right, sir. So looking at the HB, it's 76. So, I'm going to be weighing my options here. This woman is sounding cracky and everything. So what I'm going to do, I'm going to give light bed exercises, very light for her. I mean, after consulting the senior physio who is in charge there.
Okay, cool. Good. Sounds good. Yeah. One more reactions, guys. What do we think? This is a lady, she's dying. She's got heart issues. She's got kidney issues. She's got chest infections on top of that now. Yeah.
Good afternoon, sir.
Good afternoon, sir.
Actually, the treatment that might be passive, not actually active, doesn't have to involve her exerting herself because of the HB level, and also she has CKD. So in this kind of patient, based on my experience, we are more careful. We try to delay to see the markers if they are improvement in the CKD markers. But for the HB, I think we'll just do something passive for the chest and nothing active.
All right. Thank you very much, everyone. Thanks for that contributions. Yeah. Because of time. So generally, I'm not worried with the CKD. The CKD is just more reason why you need to see this patient as a physician. Honestly, these are some of the patients on our ward in Nigeria that are dying because we are not intervening in their treatment plan. I'm not worried because of the CKD. If their blood is fine, if other bloods, I'm going to talk about that later in this discussion. If other blood are fine, oh my God, they need you. This patient needs you. They really need physios. You need to get them up. So I'm not worried because of their heart failure. The ejection fractions there is just showing me at the moment their heart is struggling. That is one reason why I need to see them. So the CKD and the heart failure are just indication for me that, already at their baseline, they've got low exercise tolerance. They might likely to have low exercise tolerance, fatigue easily, reduced physiological resilience or reduced physiological reserve. But I'm not worried. So if you don't see them, generally, forget about other aspects now. Let's talk about the CKD and the heart failure now. If you don't see, these are patients that need physios. If you don't see some of these patients, they are likely to die very early. They are likely to die quickly. They are likely to decondition. So you need to be seeing them. No, I'm not worried for the CKD. I'm not worried for the heart failures. If my blood is fine, that's not my concern. Get them up, get them moving, do your stuff with them. Yeah. So now I agree with what our clinical reasonings about what we're talking about, seeing them or not seeing them. Yeah. Generally, I would say for junior physios, speak with your seniors, speak with the seniors, speak with the consultants. Now, but one thing in the questions here that must not be ignored is this patient has got iron deficiency anemia. You need to check that. Suppose this is what is written in the medical note. Is that acute or is that chronic? If it is chronic, I'm not worried. 76, get them up, do your stuff with them. They've got chest infections. What can I do with them? Chest physios, what do they need? Oh, they need cough assist. I need to suction them. I need to yanker them. I need to get them up. I need to get them moving. I'm not worried. If it is chronic, if it is acute, then you might need to check with them again. What are they doing with the patient? Is the patient for iron replacement? If the patient for iron replacement, you need to check with them. But or is the patient for blood transfusion as well? If the patient is not for blood transfusion, if the condition is not acute, there is nothing stopping you from seeing this patient. But what I'm going to say is for senior physios, for junior physios, do not see them, because this is somebody coming from a very poor background, coming from low exercise tolerance, coming from low fatigue level. You might struggle to assess their fatigue level and to grade your physios interventions with them. But so just put this patient, put the blood you see here, put it in the context of your patient to make that clinical judgment. Because don't forget, whatever decision we are making for our patient, these are acutely unwell patients. If you are meant to see this patient and you do not see them, what that means is this patient is likely to die. That is what it means. The doctor is not going to fix the situation here. They've got chest infections. They've got chest infections. They've got cracky, their chest is sounding cracky. They've got sputum retention in their chest. Nobody can fix that. That is why physios are very important in acute settings. This lady is going to die. That's what it means. So, all right, let's move on. So I've explained the backgrounds, what the HB, what their background, how their background can impact your therapy. We have explained that. Let's move forward. The second questions, I need 2 reactions for that before I say my opinion. So you've got 40-year-old man, he's been admitted to A&E, to emergency settings. He's really short of breath at the moment. She's got no significant past medical issues. Currently on 2 pints of blood, 2 units of blood. The HB is 68, and she's really sounding very chesty. So what do? Do you see them? 2 reactions, please. 2 reactions. Time is going. Yeah.
I won't be seeing them. For patients on blood transfusion, I won't be doing any rehab. I won't be seeing them at all.
Okay. Yeah. And why wouldn't you be seeing them? Hello, ma. Okay. One more reaction. Let's speak up, guys. Let's speak. Raise your hand, open your mic, speak up. This clinical discussion.
I think seeing the transfusion is ongoing. The least I can do, if it is that necessary, is to do bed exercise.
Okay. Thank you for that. All right. So what am I gonna do? First thing here, look at this patient. This patient is short of breath. What is driving that shortness of breath? Could it be from chest infection they've got? Could it be because they've got secretion in their chest? Could it be coming from that? That's one. This shortness of breath again that they've got could actually be as a result of their low HB. It could be that's why they are short of breath at the moment. Again, there is no absolute contraindication for physios, for chest physio here. But you need to weigh your risks, your options. You need to weigh you need to weigh the risk and benefit here. It's very, very important. Junior physios, leave them in bed. Leave them. Speak to your seniors. These are patients that needs to be seen by senior physios, by competent senior physios. All right. So now, if by my benefit, I feel like, oh my God, yeah, this patient is going to die if I don't intervene in this patient, you might actually see them, but your approach needs to be graded with this particular patient. And again, you need to also speak with the medical team in charge. You need to understand their escalation plan as well. If the patient suddenly deteriorates, what is going to happen? These are discussions when we need to make, when you need to weigh risk and benefit. These are discussions you want to have with the medical team. If this patient suddenly deteriorates, what is the escalation plan? If they say, oh, now they are not for full escalations, we've not really got anything to support them, oh my God, leave them in bed. Because if you do anything, if they deteriorate further, they're going to pass away. So think about all of these things. There is no absolute answer, but don't forget you are in acute settings, you are seeing patients that are acutely unwell, they are likely to die if you do not intervene. So you need a very, very sound clinical reasonings, competencies to be able to make those decisions. All right, let's move forward because of time. So what you need to remember in the slides, in those explanations is low HB is a big concern to you as a physios. Your patient can fatigue, they can feel dizzy, they can collapse, they can have shortness of breath. Vasovagal reactions is also another thing. So low HB, less than 70, they might be awaiting blood transfusion, leave them in bed. Before you see them, keep your HB greater than 80, otherwise risk versus benefit. We crack on white blood cells. So in terms of white blood cells, generally, everyone knows white blood cells, what they do generally, they fight infections, and there are a lot of indices about white blood cells as well, like you can see on the screen, neutrophil, monocytes, eosinophils, eosinophils, and there are values there. Honestly, this is useless as well. Do not remember them, they are useless. Don't cram it. So yeah, but what do you need to remember here? Sometimes we know, I just mentioned, white blood cells for infections, right? So you can find 3, 4, 5, or everything here going high up. So how do I know which one is really, really impacting my patient? If I really want to know what is going on with my patient, I'm really very concerned. For example, now neutrophil controls bacteria, they kill bacteria. If the highest among them is likely to be what is going on with my patient, if that makes sense to you. And aside from that, there are a lot of reasons why white blood cell could be high. not just because of infections. White blood cell could be high, for example, in a pregnant woman as well. You need to be aware as a physios. If you are on the gynae ward, you need to be aware of that. If you work on the gynae. Also, white blood cell could also be high if you are seeing somebody with leukemia, bone cancers. For example, white blood cell can be as high as 35, 40. So millions. So you need to be aware of that. So, but what do you have to be remembered here? White blood cells, they fight infections, depending on where you work, or the values here, you do not have to remember them. They're going to come with your reference rate. But as a physios, why is white blood cell important to us? Why do we think white blood cell is important to us? Just put the answers in the chat box because of time. Why is white blood cell important to you as a physios? So I tell you, let's go. Considerations. Why is white blood cell important? Number one, infections. You can have a patient that have come to the hospital because of chest infections, or they develop hospital-acquired pneumonia, for example. So you need to be aware. If you are doing your chest physio, you need to be looking at their white blood cells. Is it shooting up? Is it spiking up? Is it getting down? You need to monitor that. If you are doing your chest physio, you keep clearing load of secretions, but your patients keep getting bodies with lot of secretion. You need to be speaking with the medical team as well. You don't just do your percussion and shaking and leave the ward. You've not done anything for your patient. You need to be speaking to the medical team because they don't see those secretion nodes. And sometimes you might also collect some secretions, send it to the laboratories to facilitate the kind of antibiotics that needs to be given to your patient by the medical team. This is a joint work. You need to be working with the medical team closely. You don't just go to the ward, clear secretions, no clear documentations, or no conversation with the medical team and say you've done something. You've not done anything, my dear. So infections, we are worried as a physio when it comes to white blood cell. We are worried in terms of chest infection. We need to monitor that. We need to know what is going on with them. Are they deteriorating? Or why are they deteriorating? Why am I keep clearing load of stuff? Oh, it could be because the white blood cell keeps shooting up and some other inflammatory parameters. I'm going to talk about them. Again, what do you also need to be worried as a physio? Confusions, infections, they drive confusions. And one of those things we don't really, one of our underdeveloped skills in Nigeria is around these confusions. What are our OTs doing? This is one of their domains. You need to liaise. Ideally, we are meant to be liaising with our OT colleagues. They need to go on the wards. They need to progress their confusions. Confusion, physios, what does it mean? Patient can struggle to follow instructions. They can struggle to follow 3-stage command, 2-stage or 1-stage command. They can fall. And aside from that, you need to work with the OTs. OTs should be doing something to progress their cognition. The patient can be very disoriented. They might be struggling with memories, attentions, language, perceptions. They need to bring in their assessment skills, MUCA, mini-A's, and all of those things to assess their cognitions. They might be needing orientation boards. These are stuff we need our OTs to be doing. So it's a big concern to us as a physios if white blood cells is deranged. And aside from that, what other things as a physios? It could also be, your patient might be in the side rooms, they might be in isolations. What does that mean to you as a physio? I need to speak with the nursing staff. What PPEs do I need to wear? Do I need to cover my nose, what mask, what kind of mask do I need to wear? You don't just go on the ward and start seeing them. You've already read their note. You've seen that the white blood cell is going up. You need to speak with the nurse. Oh, is there any PPEs I need to wear? These are clinical reasonings. All right. So you need to know all of these things. Then aside from that, I've mentioned in terms of 3 things here. Remember confusions, remember chest infections, remember what PPE do you need to remember. Okay, one more thing is coming to my head, good, is when it comes to your rehab, when you come to your rehabilitation, there is no contraindications to physios. But just know, patient with chest infections or patient with infections, let's say they've got really, really bad infections like septicemia, for example, if they've got the reserve, if they've got the physiological reserve, they've got the resilience, they can follow instructions, get them up, get them moving, do graded rehab with them. So there's no contraindication to your rehab. And don't forget again, their temperature can be high. You might also need to look at their hubs. What is the temperature, their vitals, what we call vitals in Nigeria? What is the temperature saying? What is the oxygen level? We're going to talk about those things later. But if other things are fine, and you are really just concerned about white blood cells, there is no contraindication to your stuff. So get them up, get them to do your stuff. That's it. So that's that about white blood cells. All right, let's move down to platelets. Platelet, another very important blood to us as a physios. Normal range is here. Do not cram it. It's useless. Drop that. if platelet is very low, what does it mean to you as a physio? It means, first of all, what does platelet does? Platelets are cloggy things. They stick things together. If you got acute wounds, acute infections, platelet will go there. They will try to clog things up. They try to close the surface of wound. These are what they do, right? So what does that mean? Okay, maybe I first talk about what conditions can make your platelet to be low. Number one, if a patient has got infections, platelet can be low. It depends on the patient. Platelet can be high or low if patient have got infections. Patients that are overdosing on NSAID, ibuprofen and stuff, their platelet can also be low. Yeah, and again, if platelet is low, sometimes you might find it in the medical documentation as thrombocytopenia. Just be aware. I know this is a big term or something. Just be aware of that. Be aware. So now, as a physio, if platelet is really, really very, very low, how is that related to physios? What is my concerns with that? Let's go to it. Yeah. Generally, if platelet is really, really very low, what does it mean to you? It means the patient is at high risk of bleeding. You need to be checking that. And in acute hospitals, you need to be checking that. Your patient is at high risk of bleeding. So now, generally, I would advise if platelet is less than 50, generally, do not see them, junior physios, leave them in bed. Senior physios, sometimes you might need to weigh risk and your benefit. Put it in the context of the patient. What kind of patient am I seeing? If the patient that is at high risk of fall, this is clinical reasonings. Platelet is less than 50. Patient is at high risk of fall. If they fall, they're going to bleed. It's going to be on you. So put it in your clinical reasonings. Imagine you are seeing a patient that are very confused. They are struggling to follow instructions. Platelet is less than 50. Do you have reasons to see them at that particular moment? Why not waiting for the medical team to do their stuff first? They might be for platelet infusion and stuff. And again, let's say if it has been documented in the note that your patient is for blood platelet infusion, why not waiting if they are not currently deteriorating in bed? If they are just for rehab, so why not just waiting till after their infusions? So think about that. So all right. So what I'm going to say is keep platelets for you to do your stuff with patient. Either you are treating them for chest or you are treating them for rehab. Keep your platelet as high as 50, greater than 50. Greater than 50, greater than 50, because anything less than 50, your patient is at high risk of fall. So if you really need to see them, if platelet is less than 50, risk versus benefit, decisions to be made by senior physios, not junior physios. Now, aside from that, one more thing here. Why are we so concerned regarding chest? Why are we concerned? Why are we having these concerns on platelet if we need to manage patient chest? The reason is this. Imagine you want to do manual techniques. You want to do mark, abdominal mark, thoracic mark, percussion, shaking and stuff. The patient might bleed from that if their platelet is not okay. That's one. If you might need to do invasive techniques, one of our stolen skills in Nigeria, suctioning and stuff. That does not still mean nurses don't do it anyways. So suctioning and stuff. Your catheter can hit on the tissues. They're going to bleed from there. So you need to keep platelet high if you need to see patient from chest point of view, if that makes sense. And aside from that, you need to do positive pressure, for example, one of our skills, positive pressure, cover assist, MIE, blah, 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 all those things. If you need to do those things, the pressure might actually make the patient to bleed as well. So generally, for any patient you want to see, keep platelet as high as 50, as much as 50, like higher than 50, no problem. But sometimes you also have some patients that are chronic thrombocytopenia. That is their baseline. Now they've got platelets around, let's say 40, for example. I see them. Of course, I would say junior physios, speak with your seniors. Senior physios understand their baseline from the medical team. The fact that they've documented that they've got chronic thrombocytopenia and their platelet at the moment is 35, might not mean that is their baseline. You might need to understand their baseline from the medical team. These are discussions we need to be having with the medical team and get them to document. This is a legal documentation. Get them to document as well. And again, if a patient is on platelet infusions at the moment, just like your HB, just leave them in bed. Don't do stuff with them. Leave them in bed. It's as simple as that. Perfect. Let's crack on. Please, guys, am I making sense? Is it, or I'm just modeling everything together? Please, reactions. Am I making sense, please? Are we understanding these things, please?
Yes, we are.
Yes, you are doing a good
Yes,
job.
sir, you are making sense.
All right, thank you very much for that. Let's crack on. All right, I pop in this for our renal patient. because we need to be seeing renal patients in Nigeria as well. Yeah, they need us. So if your patient, there are a lot of renal replacement therapy. I'm not going to talk about this in this slide, yeah, but maybe in subsequent trainings we can have a little touch on all of those things. So if your platelet is less than 50, and let's say your patient is on this renal replacement therapy, so there's no contraindication for them. Honestly speaking, there's no contraindication. You can do your stuff with them. I've seen load of them in the ITU on this CBVH. No contraindication. Get them up, get them moving, do your chest physios with them. No contraindication with that. All right, let's move forward. All right, let's move down. So that is the end of FBC, full blood count. That's done, just it. Let's talk about urea and electrolyte here. So urea and electrolyte. So I'm going to connect this back to the kidney here, because kidney does a lot of stuff, physio stuff that we need to be aware of. So sodium and potassium here, I'm going to talk about them. If you remember our basic physiology, these things we've been taught then back then, action potential, if you remember. So so sodium, if you look at the picture here, you will see that sodium is extracellularly placed. So sodium is the largest extracellular cell in the body. And of course, potassium is inside. You've got loads of potassium in the body. So potassium is the largest extracellular cell. So the action potential I mentioned the other time, honestly, the one thing you just need to remember in all those big textbooks we read back in the days in relation to physio is just remember sodium and potassium, they control electrical activities in our body. That's all. The rest, useless. Just remember they control electrical activities in our body. And what does that mean? I'm looking at the slides. You guys are looking at it. I'm speaking, you are hearing me. All those things are being controlled by electrical activities. So the sodium, potassium going in and out, going in and out, going in and out, going in and out. That's how it's been worked. So what does that mean? Your brain cells, they are using sodium and potassium. Your heart cells, they are using sodium and potassium. Nerve conductions, all of those things are, our life generally is based on electrical activities. That is the point I'm trying to make, if that makes sense to you. So now, so just imagine, if sodium and potassium go wayward, what does that mean to a patient on the ward, to a poorly lady on the ward, or to that man on the ward that is dying, to that dying patient on the ward? So you need to be aware of sodium. You don't just go on the ward and start seeing poorly patients. You need to know your sodium. You need to know what is going on with your potassium, because you know, if the potassium is very, very deranged, they can have problem with the brains. They can have problem with the heart. I'm going to talk about that in a JV. That's that for now on sodium and potassium. I'll come back to it later. Urea and creatinines. I'm going to talk on urea, creatinines, and electrolyte glomerular filtrate rates. So let's move forward. Let me start with urea. First of all, so urea, what does urea mean? Urea is just proteins, breakdown of proteins. They are product of proteins in the body, breakdown of protein in the body. That is enough. Just remember that urea is made from the proteins, breakdown of what you eat, the food you eat, and all those things. That's urea. And urea is being removed by kidneys. Kidney removes your urea. It's as simple as that. Simple as that. You pass it out in form of urine. As simple as that. Now, what are the conditions that can make urea to really, really very high? Dehydration is number one. Dehydrations. Imagine you've got a patient on the ward. They are really poorly. They are not eating well. They are not drinking well. Yeah, I need to go. Look at the urea. What's going on with urea? It does not necessarily have to be patients. They have been the patient does not necessarily have to be on renal ward. That's the point I'm trying to make. They are not necessarily have to be diagnosed of kidney failure or something before you start thinking about urea. Or you've got a patient, let's say, this is not very common in Nigeria, but very common here. Let's say you've got a patient, they had a fall, they had a long lie, they had a fall, they are elderly patient, they had a fall, they had a long lie on the floor, let's say for longer duration, let's say for 3 days, 4 days before the ambulance team or anything comes up to pick them. So, you know somebody on the floor is not eating, is not drinking. What is it? The muscle will start breaking down from dehydration. Kidney will start failing. All of those things. So what do you know? What do you have to check? You need to be checking their ureas. Their urea might start getting up. It might start rising up. You need to be checking their ureas. It's very important you check their ureas. So urea is very important. Aside from urea, I mentioned something the other time. If you remember, under HB, let's say if HB is low and MCV is low, if you remember, it could be that somebody is dropping blood from somewhere, like maybe in the patient that is menstruating, it could be because of that. Their HB could be low because of that. It could be somebody breathing that from their upper tummy. What the medical team normally do is sometimes they go ahead to check the urea as well. If the urea is high, it is likely to be an upper GI bleeding. They will just say, oh, request for CT scan or ultrasound. Let's see what is going on in the tummy. So just have a clue. Just you might, I don't know, by chance, you might come across those kind of patient. You look at their HB, they had a fall, you look at their HB is deranged, you look at their MCV, you look at their urea, just have their clinical reasoning. You need further investigations. Hold down your treatment for a while. They need further investigation. That's what it means. That's what it means. Speak with the medical team. Oh, I think this patient, this is my reasoning, this. What do you think? That's it. Then again, chronic kidney diseases, their urea can be deranged as well. But one good news about urea, irrespective of the value, honestly, either it is very, very high or whatever, we don't care. I don't care as a physio. You shouldn't care as a physio. You can only be care because of dehydrations, but doing your stuff with them, doing your stuff, like, oh, they've got chest infections, I need to see them from chest point of view. Do your stuff, no contraindication. Oh, they are on bed. Oh, they are on bed. Their urea is high. What do? Yeah, do your stuff with them. No contraindication for urea. Get them up. But one thing about urea is this kind of patient, if their urea is really very high, what is going to happen to them is they might be really poorly in terms of shortness of breath. They might be feeling dizzy, and they might have a reduced exercise tolerance. These are stuff you need to know as a physio. But from rehab point of view, there's no contraindication, honestly speaking. And again, from physio point of view, urea could also be high because of dehydrations. Have you had that conversation with the medical team? I know they should be aware as well, but show that you know what you're doing as well. And even while at the bedside, while you are with the patient at the bedside, basic things you can do: offer them oral fluids, give them water, stop within your therapy section, offer them fluids, because urea and water, they have a very, very good relationship. These are stuff we need to be doing with our patients. But generally speaking, from rehab point of view, from chest point of view, there is no contraindication. But just remember urea, that when urea is deranged, it could be because of a lot of reasons. It could be because your patient is dehydrated. It could be because they are bleeding from somewhere. It could be because they've got kidney issues, but there is no contraindications. Offer them fluids if they are not nail by mouth. Nail by mouth is patient cannot drink and eat. Maybe they've got this, what's it called? They've got dysphagia or something. So if that is not the issues, offer them fluids during your therapy sections, and you start progressing them gradually. And you grade your therapy to meet their exercise tolerance. It's as simple as that. All right. We move to another one, creatinines, because of time. For creatinines, one thing creatinines is just product of muscle breakdown. Imagine a lady I mentioned the other time. She had a fall, long lie. Before the ambulance came, it's been a long time. So this kind of patient, you need to be checking their creatinines. Now, or you've got a patient, an elderly patient in Nigeria, she's not been moving, she's got reduced mobility recently, she's not really been moving around, she's always in bed every time, not eating well, not drinking well. If you need to see them on the ward, now they are being admitted in the hospitals, you need to check their creatinines. My dear, you need to check their creatinines. But because this kind of category of patient, aside from the fact that they might be having, even if they don't have kidney problems, you also need to check their creatinines. Because somebody not moving, hemobilizations is one of the risk factors that can gradually make your muscles to start breaking down. And when muscles start breaking down, what happens? Your creatinines will start getting plenty in your blood. And before you know, you will start having kidney issues. So immobility immobility is really has a great relationship with kidney issues. So that is why we need to be getting involved in those patients on the ward. We need to go there, get them up, get them moving. You're getting them up, your rehab that you are doing with them, what you are helping them to do, you are helping them to prevent kidney issues. That's why we are very important. So, and aside from that, let me say this again, and aside from that, so the marker, now, let's say now you are currently on renal ward now. You've got a patient with acute, they have been diagnosed of acute kidney injuries. Of course, this equation here that I put here is just to understand how kidney issues is being diagnosed. I'm not going to speak about it. It's not too relevant to you as a physio. Don't bother yourself about that. Forget about that. It is useless. But one thing you need to know as a physio is for acute kidney injury, to diagnose an acute kidney injury, you need your creatinine. Creatinine is the marker. Creatinines are not reabsorbed in the body. Your muscle, your body produce them. Your muscle produce them. They are waste product from your waste product from your body, and your kidney should be flushing them out of the body. If you don't reabsorb them, they should be flushing them. But when the body start retaining them, issues start coming up. Kidney issues start coming up, if that makes sense. So that is how it works. Well, and again, for creatinines, it's just like urea. If your creatinine is high, you find a lot of patients, high creatinines, high urea. Don't be concerned as physios, but you can only be concerned when it comes to tolerance. They can fatigue easily. They can have low endurance. Just like the CKD I mentioned the other time. And you guys now correlate. You are not concerned if other bloods are fine. For now, the only blood that I've mentioned that it is of great concern to you as a physios, that you might think of, oh, I don't need to do stuff. If this is low, it's just hemoglobin for now. With urea, with creatinines, get them up, no concern. If other bloods are fine, no concern. But they can really be fatigued if your creatinines and ureas are deranged. If that makes sense, we move forward. So I've explained this. High creatinines, it might mean acute kidney injuries. It might mean that your patient are dehydrating. It might mean that your patient they can really, really get dizzy. They can fatigue easily. They can also have solely limbs. You can have fluid retention in their limbs as well. Then again, no contraindication to physios, no contraindication to chest, no contraindication to rehab. I talked about the last one here on the kidney. So estimated glomerular filtrate rate. So what this means is this in acute settings is not 100% very relevant to us, but because this is used in the diagnosis of a chronic kidney disease, actually. So now, don't be worried about this picture here. It looks complicated, but I'm going to keep it simple. So generally, the value for this is just 90 to 15. So if the value for eGFR is less than 15, the patient is on stage 5 acute kidney injuries. And how does that work? I will not just be worried. You may just want to be worried about stage 4 and stage 5 as a physios. And why are you worried? Because these are dialysis patients. They would normally be dialyzed. And with dialysis, what that means is it could be that maybe they are retaining potassium that they need to, it could mean that maybe their creatinine is going high up or something. So, and again, for the fact that they are stage 4 or for the fact that they are stage 5 does not still mean you cannot do your stuff with them. Do your stuff with them if other blood are fine, and if they have mentioned that they are advanced kidney disease or stage 5 disease, you can still do your stuff with them. But again, these are patients that can really, really be very fatigued, because during this stage, their creatinine might be off, might really be very high, the urea might really be very high. They might be a dialysis patient, and in the process of dialyzing a patient, their HB will go low, and you need to be worried now. I need to think about, do I need to do stuff now because their HB is low, or do I need to wait if they transfuse them? Think about what we discussed initially. But if HB is fine, if their HB is fine, and other things are fine, do your stuff. No worries. Just forget about creatinines and urea. Do your stuff with them. So, and again, so for stage 5 again, these are patients that might really be, approaching maybe renal transplant as well. I've met a couple of them here, renal transplant. What are you seeing them for? Do you need to switch your treatment plan to pre-rehabilitation now, getting them prepared for the surgeries they want to have, big surgeries they want to have? Or do you need it to come in after their surgeries, after they have their renal transplant? And after their transplant again, put it in the context of a patient. These are patients that are likely to fatigue easily. They are likely to have reduced tolerance, exercises. How do we grade their exercises? We're going to talk about those things later on in some trainings. So stage 3, stage 2, stage 1s are usually modify the risk factor. They are smoking too much. How do we get them to stop smoking? Their blood pressure is deranged. They've got high cholesterol and all of those stuff. So how do we get those things to be lower? Sorry. So how do we get those things to be?
Sorry, someone just posted. They are enjoying it, but they said you are too fast.
So okay, all right. Sorry about that. I will try to slow down. Sorry about that, guys. Sorry about that. So like I'm saying, stage 1 and stage, I'm just being mindful of time because we've got a lot of stuff to cover, honestly. So Stage 1, stage 2, stage 3 is just modifying risk factors. But advanced stage are just maybe stage 5. They might be on dialysis. They might, peritoneal dialysis, hemofiltrations, another one. So we talk about those things later on. So what do we remember in this kidney stuff here? Urea, creatinines. Guys, if you don't remember all these stories I've been telling since, urea, creatinines, no contraindication to your physios. But remember urea and creatinines from exercise point of view. They might have tolerance to exercise. They might fatigue easily. They might be short of breath. How do you progress them? So part of your rehab plan should be, how do I progress their exercise tolerance? And while you are doing that, you are monitoring their urea. Is it getting down? What is their trend? Or is it shooting up? If their creatinine is shooting up, they might be needing further dialysis. They might be needing to flush, to filter their blood. You need to be having this conversation with the medical team. Yeah, so that's how it works. And again, creatinines, remember, the second thing you need to remember in all of these stories is creatinines as well is marker for acute kidney injuries. EGFR is a marker for chronic kidney disease. These are what they check if they need to make the diagnosis for chronic kidney disease. Hope I'm making sense. Am I making sense, please?
Not sure.
Sure.
Yes.
All right.
Yes, sir.
Thank you. All right. So let's come back to sodium. Don't forget, I mentioned the other time that sodium and potassium action potential, if you remember that term, sodium and potassium, they regulate our electrical activities in our body. They control our electrical activities, your brain, the way your brains work, the way your heart works, the way the way your visual nerves, the way they are firings, the way your auditory nerves, or anything nerve conductions. Sodium and potassium, very important. So normal value, don't remember it, very useless, forget about it. It's going to come up in your reference range. Now, I need to be worried if sodium is low. I need to be worried if sodium is high as a physio. What are the conditions? Clinical reasons now. What are the conditions can make sodium to be low? Oh, poorly lady on the bed. Poorly lady on the bed now. Let's say they are not eating well, they are not drinking well. They are oh no, don't let me go in that lane to really make it clear. If your sodium and water, they have a very big correlations. They have a very, very big correlations. If your patient, let's say your patient is on the bed now, they are being poorly, they are dehydrated, and they are being given lot of fluids, or in a well-hydrated patient, or in a patient that have fluids in their body, fluid retention. Let's say they've got liver problem, they are retaining fluid because of that. They've got kidney problem, they are retaining fluid because of that. They've got heart failure, left ventricular heart failure, or right, whatever one, they are retaining fluids in their body. These are conditions that can make your sodium to drop, to go low. That's what it means. And again, another thing that is very common that I've seen in my clinical practice here is you might also find patients with blood sugar, that their blood sugar is really very high. The medical, they will call it pseudo-hyponatremia. That is a forced sodium dropping. What that means is because of the blood sugar, is the one actually making the sodium to go really low. And the reason is not looking like that. Just be aware of that. Anyways, so now sodium, low sodium, what could be driving that? Fluid retention in the body, just remember that, as simple as that. High sodium, dehydration. You got patient in the bed, he's not eating, elderly patient, he's not eating, he's not drinking. What will happen? They are not moving, they are always in bed. Urea can go low, creatinine can go, urea can go high, creatinine can go high, sodium can go high. Correlate things, that's how it goes. So now, if sodium is really, really high, so if sodium is high or if sodium is low, why are we concerned as a physio? One thing, confusion. That's number one. Because we have mentioned to you, sodium controls electrical activities. One of those things they control is your brain. If it is too high or too low, confusion, your patient can be confused. What are you doing? Are you speaking with the medical team? What are you doing? Are you getting your OT colleagues? We need to train our OTs. Are we getting your OT colleagues to come to progress their cognition? They might be lacking capacity to do stuff. They might be disoriented. They might be having memory stuff, memory issues. Are we getting our OTs to be doing stuff with them? Are we supporting them? So we need to be thinking about those things. And again, aside from that, your patient can go in coma. Your patient can go in coma. They can die if the salt is too low because their brain are not getting enough stuff they should be getting. They are not firing the way they should be firing. Their cerebral function can be dropping. So think about that. So, and again, physios, generally, you need to be worried about sodium. But let me say this again. Sodium is an amber. What I mean by amber is it's not like a red flag, just like your urea. Urea is not, to me as a physio, urea is not a red flag. Creatinine is not a red flag. Sodium is also not a red flag. It's also a number. It's just you being worried and correlate what sodium is, correlate that to your patient. So I would say generally, junior physios, sodium less than 120, leave them in bed. Speak to your seniors. Senior physios, weigh your risk and benefit. Put it in the context of your patient. My patient, I've met sodium 118, 1 something something, and they are fine. They are not concerned. They are not worried. And again, but some of them might be confused. But I just need to think about what are the medical team doing? What can I get my OT colleagues to support them while I'm also doing my stuff? But again, remember, let me make it very simple. Keep it simple. If sodium is less than 120, junior physios, leave them in bed. Senior physios, put it in the context of your patient. Let's move forward. Potassium. Let's move to potassium. So potassium, yeah. If there is one thing I'm going to tell somebody to cram today, honestly speaking, I'm going to tell you, please cram the value for potassium. Do you know why? I'm going to tell you the reason. The reason is this. There are a lot of deaths in acute hospitals very related with potassium. Do not joke with potassium, please. Please cram the value. And it's not difficult. 3.5 to 5.3. Sometimes you can have it depending on where you work. Sometimes it could be 3 to 6, it could, I don't know, but depending on where you work. But this is rough estimates according to guidelines that you will find in most hospitals across the UK, outside the UK, you'll find this. But again, if whatever it is in your hospital, please cram the value. Why do you need to cram? There are a lot of deaths in acute hospitals that are related with potassium. Why is potassium so critical? Because potassium, if your potassium is too high or too low, patient will start having cardiac arrhythmia, their heart rate will start fluctuating, will start jumping up. And before you know, they will go into atrial fibrillations, and before you know, they will die. So you need to be careful with potassium. That's the point here. So what condition can actually make your potassium to be low? If your patient is throwing up, vomiting, they are throwing down, diarrhea, losing fluids, they are losing potassiums, the potassium can be low. The patients that are overdosing on NSAIDs, their potassium can be misbehaving. What reasons can make potassium to be high? And again, physios, Nigerian physios, Ramipil, these are medication to control blood pressure. If you are going in to see a patient on the acute wards now, are we checking their potassium? So we need to be checking their potassium. We need to ensure potassium is within range before we see our patient. Because remember again, there are a lot of deaths in acute hospitals that are very much related with potassium. Don't joke, you don't want to mess with potassium. Do not mess with potassium, please. So that's that about that. So again, let me connect it back to kidney because we might need to be working on renal ward. Back to kidney. So kidney, of course, one of the salts in the body that our body keep removing and removing, one of them is potassium. So when you now start retaining potassium, let's say you've got kidney injuries now, or acute kidney injuries, or stage 5 kidney injuries, you start retaining potassium. What happens? The heart rate might start misbehaving. Of course, before they start retaining potassium, their urea and creatinine will start misbehaving as well. So just remember, if I'm on renal ward, I need to keep monitoring my potassium. That's the point I'm trying to make here. Aside from urea and creatinine, I don't want to also mess with potassium. Anyway, anywhere you find yourself in acute hospitals, always monitor their potassium. You see why I'm repeating potassium? It's really, really very important to us to do not mess with potassium. All right. So now, considerations for physios now. How we say generally, physios, if your potassium is deranged, is not within 3.5 to 5.3 in acute hospitals, leave them in bed. Junior physios, don't do it. Leave them. It's dangerous. Now, senior physios, if my potassium is less than 3.5, yeah, and I need to put it in the context of my patient as well, because I don't know. It could be that if I don't see them, they are going to die. Yeah, from chest point of view, they do not die. So I need to put it in the context of my patient. Okay, now, I need to speak with the medical team as well. What else do you need to check as a physio? I just mentioned that potassium controls the heart rate jumping up and down. So you need to be checking their potassium. You also need to check their heart rate as well. You need to check what values is the heart rate. Is the heart rate stable? For me to start rehabbing this patient, is the heart rate stable? And again, I also need to check their energy level. Check your patient, are they acutely deteriorating? Imagine you've got somebody in bed, is acutely deteriorating, their potassium is high up there, and you think that your physio is going to save their life. No, you are you may be endanger the life of a patient at that particular time. So weigh your risk and weigh your benefit. That's it. And for dialysis patients, generally 3.0, do your stuff. 6.0, you can still do your stuff. But if you are not competent and confident with that, speak with the medical team, because for a kidney patient, their heart is already desensitized to potassium already. So with 3, you can still do stuff with them. With 6, you can still do stuff with them. These are clinical risks because you don't want to continue to keep your chronic kidney disease patient on bed, acute kidney disease patient on bed. They're going to deteriorate, they're going to decondition there, they're going to get chest infection, they're going to die. So you need to think about that. So there's nothing wrong if you need to see them. But again, speak to the medical team. Junior physios, if the range, leave them. Senior physios, put it in the context of a patient. If you've now got a cardiac patient, let's say you're on a cardiac ward now, they've got recent heart issues, or they've got cardiac surgeries, or they are known heart failure patients or whatever. So now, I would say generally, keep potassium between 4 to 4.5 before you see them. This is what guidelines generally recommend. So if anything less than 4, there's another parameter you might be needing to check. You might be needing to check their AMP. I'm not going to talk about AMP here, but just remember these things. You might be needing to check their AMP for you to decide either to see them or not. Why are we so concerned with potassium and heart? Don't forget, potassium is very linked to the heart. Somebody just did heart surgeries. They just touch the heart. They just put a stent in the heart. They just do percutaneous. They just do TAFI or STEMI or whatever things they've done to them. So already, even before you go in to see them, their heart rate might likely to be high already. So they might even be on medication to crash their heart rate. So do you now want to just jump in and say, yeah, potassium 3.5, let me go see them? You might endanger their life, because any rehab you're going to do with them will make their heart rate go high up. They might pass away. So keep potassium within range, within recommended range. And again, speak with the medical team before you go in. And again, grade your approach before you see all of these patients. All right, let's crack on. That's potassium. So we move down to inflammatory markers. This is also another thing that is very relevant to us as a physios. Infection markers. I have mentioned one infection marker today, which is white blood cell. CRP, again, in acute hospitals, is also very important to us. CRP, C-reactive proteins are made by your livers. When there is infection going on in your body, liver will make a lot of them. So CRP will go high in your blood. For the values, don't cram it. It's useless. It's not relevant. And again, for CRP, these are non-specific infection markers. Let's say, for example, now I'm screening the patient note. I look at their blood. I look at the CRP values, and it's way high there. All right. So it doesn't tell me anything. It just tells me that there is inflammation, there is infection going on. It doesn't tell me what is it, bacteria, is it this, is it that. For me to be able to know, I might need to go check their white blood cell. Can you see the connection, guys? So now for ESR, these are chronic infection markers. It's not very relevant to us in acute setting, in acute hospitals. But people in MSK, I'm aware we've got another person to come talk about MSK. She's going to talk about ESR with us. These are stuff we need to be checking. Somebody have got fibromyalgia, they've got romantica, they've got, what do you call it? They've got sciatica. Are we checking all of these things in Nigeria? So these are questions we need to be asking ourselves. Anyways, let's move forward. I'm not in for MSK. Let's move forward here. All right, let's talk about INR. INR is also another clotting factor. I have mentioned, connect them, infection, CRP, white blood cell. Great. Platelets, clotting factors now. Platelets, I've mentioned platelets. This is another one here, INR. So INR is also another clotting factors. So for INR again, if INR is higher than expected or lower than expected, your patient can bleed. That is why you are being concerned as a physios. If you need to see a patient from chest point of view, you need to check their platelet level, you need to check their INR level. Because if you are jumping on their chest, you're doing your manual techniques, you're doing your percussion, you're shaking your mark, your positive pressure with them, or you're suctioning them, you can actually make your patient to bleed. How are we checking their INR before we see the patient? These are questions we need to be asking ourselves. And again, I would say generally, I hear now greater than 2 junior physios, leave them, speak with your seniors. Senior physios, you can put it in the context of a patient. Well, if I need to see them for mobility now, for example, I need to assess, is my patient fine? Are they able to follow instruction? Are they not at risk of fall? I can mobilize them, I can rehab them, no problem. But if the INR is deranged and they fall, they can bleed and it's going to bleed on you. So think about that. And again, you can also have some patients that chronically their INR is very, very high. For example, I give you a good example. Patients that have had, maybe they've had heart surgeries in the past, they've had maybe metallic replacement to their valves, or they've got any valve replacement or anything like that. So, or they've got pacemaker. These are patients that will normally be on varafins for long period of time. In fact, if you've got metallic heart replacement, you're going to be on varafin for the rest of your life. That's what it means. So if you check the INR of this particular patient, the INR will be way high down there. So if you've got that kind of patient, no concern, get them up. You should have that clinical reasoning. Okay, yeah, I think the INR is high because of what they've got. It's as simple as that. Do your stuff with them. No concern with that. But if you've got this particular patient presented in the hospitals, junior physios, part 5, not band 5, sorry, part 5, intense, early careers, escalate to your seniors, let them make those decisions for you. And all of those things should be entering in your note. It should be in your analysis. Clinical decisions to mobilize them because they've got metallic heart replacement, a long-term varafin user. All of those things should be in your notes. Oh, all right, because these are legal documents. That's it. All right, let's move forward. I'm going to talk about blood sugar. We're rounding off on blood. I'm going to talk about blood sugar here. Of course, we are all familiar with this one. I would just say, of course, if your blood sugar is low, your glucose is low, that's hypoglycemia. If it is too high, that's hyperglycemia. So the normal range, and again, units can be different, categorizations can be different, depending on where you work. Yeah. So I would say normal values 4 to 8, 3.9 to 3.9 to 7. That's normal value, depending on where you work. I would say generally in acute hospitals, if your blood, if your sugar is less than 4, leave them in bed. It could be, for example, now let's say I've gone to see a patient early in the morning. The nurses have run the fasting blood sugar, they've run the early morning blood sugar for them, and the value says, let's say 2.5 or something. It's as simple as just leave them, think about speaking with the nurse, have they had their breakfast, or even ask the patient, have they had their breakfast this morning? It could be that is why their sugar level is low. Clinical reasoning, speak with the nurse, come back later in the day, ask the nursing staff to run another test before you come, and you check their note. And if it is higher than 4, no contraindication, do your stuff with them. It's as simple as that. Simple. So, and again, because if you go in to do your stuff, or you did not even check the blood sugar, and you just go in, you mobilize them, they can collapse, they can fall, because they've got low reserve, they've got low energy to do what you are subjecting them to be doing. How are we checking all of these things, physios? So think about that. And again, hyperglycemic, of course, we know the impact of sugars on rehab. I'm not going to talk about that. If it's greater than 10, if you are using this parameter here, so keep them in bed. You might want to speak with the medical team. What are they doing? Or are they chronic hyperglycemia? If you've got some patients like that, you might need to be speaking with the medical team. These are decision making that you need to be involved in. All right. So I've popped this one in. This is called glycerated hemoglobins, meaning glucose that is binds to hemoglobins in acute hospitals. Hello. Hello.
We can hear you, sir.
All right.
Continue. I've muted him.
Okay. All right. So in acute hospitals, you're gonna find these. Of course, this is actually used in diagnose a patient for diabetes. For you to for medical team to arrive that a patient have got diabetes, they need to do this, because this actually measures the amount of glucose that is on red blood cells for like 3 months. It's very reliable for like 3 months compared to the random one you do every day, drinking and stuff. Those ones are subjected to eating, drinking and stuff. But this one for 3 months, your accumulated blood sugars on glucose for 3 months. So if you want to make the diagnosis, this is what they actually request. If you work in acute hospitals, you read the notes, you check the blood here and there, you find all of these things to make the diagnosis of the patient for diabetes. Anyways, but this one here, this is just like a treatment. It's just to be aware. This is called variable rate intravenous insulins. let's say you've got a patient on the ward now, they are poorly, they are not eating, they are not drinking, and their glucose is very low. You might find them on this, giving, like, it's just a way of giving them an insulin. If they cannot take it orally, it's just a way of giving them an insulin. So anyways, I will talk about that later. I will break it down, but for now, just little stuff. Let's move forward. So what have we learned before I talk about liver up to now? Let's recap. What have we learned? HB, I need to be worried as a physio. If it is less than 70, they might be for transfusions. Less than 80, put it in the context of a patient, but you can HB greater than 80, you can still see your patient, no concern. Now, potassium, 2 red flags so far. HB, potassium, not 2, maybe 4. HB, potassium, platelet, and high NR, 4 red flag. 4 red flags so far. If HB is really low, sorry? So if HB is really low, you need to think about it. If platelet is really low, think about it. Your patient can bleed. If INR is really low or really high, whatever, your patient can have a blood clot or they can bleed, whatever. Think about INR. And again, I'm not worried. Urea, creatinines, I'm not very worried. I can do my rehab with them so that they might get fatigue easily. That's it. Potassium, don't joke with potassium. 3.5 to 5.3. Keep it in that range. Junior physio, 3, 6. Senior physios, put it in the context of your patient. Look at their heart rate. If they are not acutely deteriorating, if their heart rate is fine, you can do your stuff with them. Simple as that. All right. Liver function test. I'm not going to spend a lot of time on this because if I sit down with it, it's going to take me a load of time. But I will just say few things about liver function test. Be aware of albumins. Albumins, what do they do? Albumins are proteins that are made in the liver. On what conditions can your albumin be low? Just brief things I'm going to tell you. What's the role of albumin? First of all, what albumin does is keep content in place in your blood. Osmotic pressure. Just remember it like this. Oh, it arranges things in orderly manner in your blood. That's what albumin does. Forget about those big physiology. It makes things well organized in your blood. Now, what conditions can make albumin to go low? Don't forget, this is coming from the liver. This is being produced by the liver. What conditions? Think about these things. If let's say, for example, now you've got infections going on, you've got inflammation going on in your blood. So what is going to happen? So what is going to happen there is that your kidney, rather than producing albumin, your kidney will concentrate on some other areas like producing CRP, producing infection markers to be able to fight infections. So what will happen in that regard? Your albumin will drop. And once your albumin drops, what happens to the content they are holding in the blood? The content will just go wayward. What will happen? What is the impact that you can see as a physio on your patient? They will start having fluid retention. Oh, edema in the hand, itching edema in the legs. Just remember albumin as that. Albumin is, what do? They arrange stuff in the blood. They keep them in an orderly manner. If anything happens, they go low. What happens? Edemas. It's as simple as that. So bilirubins. The bilirubins are also waste products. Of course, these are stuff that make your urine to be yellow, your poo to be, your fecal matters to be brown or whatever. So bilirubins can go up if there is issues inside the liver or issue outside the liver, like in your gallstones, in your pancreas or whatever. Bilirubins will go up. I'm not going to talk a lot of stuff here. So in your kidneys, in your liver, in your liver, you've also got some enzymes. Let's say you've got a patient now. When do you actually need to be checking liver function test? When? The question is, if you've got a patient now, let's say they are concerned, you are reading the medical note, their concerns are around, oh, liver issues, they're going to have liver. I don't know if you do that in Nigeria anyways. But here, if you've seen a patient, yeah, they are concerned, they're going to have liver transplant, they're going to have this, there's infection of the liver going on, then you might just need, let me just check their liver enzymes. Oh, what is going on here? It's the amino, blah, blah, blah. I don't know. So, so check their liver enzymes. If it is high, yeah. Oh, there is a great liver concerns here. If it is low, okay, their livers are fine. But let me tell you this is not a red flag. This is not contraindication to whatever thing that I want to be doing with them. I'm not worried. I'm not concerned. But what blood do I need, even with their liver issues, what blood do I need to be concerned with? I need to be concerned with HB, I need to be concerned with potassium, I need to be concerned with platelet, I need to be concerned with iron, I need to be concerned with maybe infections like CRP, white blood cell, checking where is it going. I'm not really worried about all these things, honestly speaking. I'm not really worried. So that's why I'm not spending a lot of time. But if you are in for pre-rehabilitations, you might just want to check, oh, what's going on in the liver, what's the enzyme saying? Just be aware of this if you are in that world. Anyways, I'm not sure if we do this in Nigeria. So we move forward from there. So I'm not going to talk about this slide as well. So other ones here that I'm going to talk about is for calcium or magnesium or vitamin D's or parathyroids. All of this one here, they are not, yeah, they can be deranged as well. For example, now let's say you've got a patient, their bones are brittle, they go to Malaysia, whatever, or even a renal patient, for example. Renal patient, their potassium can be low or high or whatever. I'm not worried. I'm not worried. You shouldn't be worried as a physio. Don't forget, one of the things that cause what do you call it now? Somebody to be having issues with potassium or with calcium, rather, not potassium, calcium, is immobilizations. So if you've got a patient now, let's say you've got a patient, their potassium is deranged, high or low now. They are in bed. So do you still want to keep them in bed? That's lack of competence. You need to see them, you need to get them out. So don't be worried with potassium, don't be worried with vitamin D or whatever. I'm not worried with that. So that is why I'm not spending a lot of time on them, but just be aware of that. And aside from that, let's come to cardiac stuff now. I'm going to talk about BMP first of all. So what BMP means, let's say you've got a patient now, you are on a coronary ward, or you've got a patient, you are covering an emergency ward now. You've got a patient, they have been admitted because they had a collapse, they had or let's say collapse, for example, or maybe they faint or something from their cardiac issues, and we want to check their BMP. What BMP means is brain nitric uretic peptides, or some people will say B nitric uretic peptides. So what that means, what BMP means, they are proteins that are produced by the ventricles. What does ventricle means? One of your chamber in your heart that pump blood around the body. Or yeah, so these are produced by the ventricles. Now, so what BMP? On what condition does the heart produce BMP? The heart produce BMP if your heart are struggling. If the ventricles are struggling to pump blood out of the body. The role of ventricle is to pump blood. If your ventricles are not struggling to pump blood, to pump fluid out of the body, and the fluids they are meant to be pumping out, they are coming back to them. There's a backflow. So the ventricles are now getting baggy, they are getting bigger. So the heart will start producing BMP. And what is the role of BMP? Why are they being produced? The role of BMP is just to reabsorb those fluids. That's why BMP is being produced. So what does that mean to me as a physio? BMP, I am not worried. Not worried. If you leave your patient, you are not doing well, your competency needs to be queried because of BMP. I'm not worried with BMP. But you should just remember, oh, BMP, oh, what does BMP mean? Oh, yeah, their heart is struggling, their ventricle is struggling. That's what it means. What does that mean? They might be struggling with tolerance, fatigue, exercise tolerance, fatigue, but that is not enough for me to leave them in bed. That's what I'm saying. That is not for me to see them from chest point of view. The medical team will be doing their stuff. You should be doing your stuff, doing your rehab, doing your chest, whatever things you are seeing them for. So that's how it works. Troponins as well. Troponins is also cardiac markers. Let's say a patient have got maybe cardiac arrest. I've seen a lot of patients in recoveries that they've got cardiac arrest, they faint, and I've been called to come see them, or I pick them up by myself. I'll go in, I'll walk in, I'll see them. Now, what troponins means is troponins is just will always be released. If, for example, now if the heart is also struggling as well, even troponin is being released as well. And again, this is just a matter to tell you, oh, recent cardiac issues has happened. But that is not enough again not to see this patient. Because again, this patient might be struggling with fatigue, disease tolerance, exercise tolerance, all of those things. But again, troponin could also, in another context, let's say somebody have got blood clot in the leg, troponins can also be high as well. Troponins could also be high. If somebody have got clot in the legs. Let's say even in a pregnant woman, troponins could also be high. Or somebody that have got infections, troponin could also be high. So put that in the context of, let's say, for example, now I've got a patient, now you look at their leg is swollen, it's painful, there is redness, the MDTs are querying DVT. I can just, to be more clinically sound as well, and they've had a recent blood, I'll just look at, what is that troponin saying? Yeah, troponin, yeah, hi, yeah, because of this. It's as simple as that. But of course, if that is the case, DVT, you might need to just think about it. When do I need to see them? What are our protocols? We need protocols in Nigeria too as well. Here where I work, in some NHS, it could be, okay, if your patient is on clepsin, we call it enoxaparin here in UK. If your patient is on clepsin, enoxaparin, after 1 day, there's no contraindication. Get them up, get them moving. In some hospitals, it could be after 48 hours, whatever your protocol is. Once they are on that clepsin, they are on that medications, there is no contraindication. Do your stuff. Do not leave your patient in bed. D-dimer, same thing with D-dimer. D-dimer is not an including test, it's an excluding test. D-dimer could be rice. I know every one of us, when we hear D-dimer, we always think about DVT. Yeah, that's right, but it's not just DVT. D-dimer can be rice. Somebody have got, what is it? If somebody's, D-dimer is just showing that there is infection going on, inflammatory cascade going on. So if somebody have got an infection, if somebody have got clots, if somebody is pregnant, D-dimer could also be rise up, be coming up as well. So that is not, so for D-dimer, put it in the context of a patient. We got concerned at the, what's it called, on their arm. Their arm is swollen, it's painful, it's red. Oh, is that DVT? What is that D-dimer saying? Put it in the context of your patient. In that regard, what is your protocol saying before you start seeing your patient? Think about those things. But again, so it's all about putting it in the context of your patient. So that is that about that. So so what do we remember before I go to the case study? What do we need to remember here? Ladies and gentlemen, remember HB in no category of your patient. Whatever words they are, HB is very crucial. If HB is low, they can collapse, they can die. Keep HB as high as 80. Now, if I need to do chest physios, what are the things I need to be checking? From infection point of view, to know if their infection is improving or getting better or getting worse, I need to check CRP. I need to check white blood cell. For my techniques, for chest physios, I need to be checking platelets. If I'm not checking platelets and their platelet is really low, you can make your patient to be bleeding. You should be arrested for that, for not doing the right thing. Even though you can still do the right thing and your patient can still bleed, you have good reasons to defend yourself. So platelets, you need to be checking platelets. You need to check their high NR for you to before you do your chest physios. So, and again, for me to mobilize patients in any ward my patient is, I also need to be checking their potassium. Potassium is very, very key for me. Let's say now I'm in haze. I'm being called to different wards. Oh, these are poly patients. They're being called to different wards to come and see patients now. Now, I'm really in haze, and I just want to quickly see this particular patient before I go see some other ones. What do I really need to check? Please ensure you check your hemoglobins. Ensure you check your potassium, no matter how busy you are. Ensure you check your potassium. Ensure you check your high NR. Ensure you check your platelets. And ensure which other ones is important. Platelet, high NR, HB, which other ones? I think those are the key ones. Please check those things before you go in to see your patient. It's as simple as that. All right, before I get questions on this, let's have case study discussions here. So we're going to open the mic again. But before that, let me read. The question says, you are working on AMU, acute medical ward in Nigeria. You have been asked to see 85-year-old lady. She had a fall. And this is reported that the patient was in the floor for a long period of time. Your patient had a long lie. That might be very difficult in Nigeria, but just imagine the patient they've had repeated fall. Now they are in bed in Nigeria for a long period of time because of pain. They could not mobilize again. They are groaning in pain in bed. They've been lying in bed so long. So now this is their blood parameters. Sodium 122, CK. What is CK? I'm not going to tell. I will ask you guys to figure it out. CK 4,000, CRP 300, white blood cell 400, HB 55. Can you interpret these bloods and what are you concerned with? And if you need to request for further things with the medical team, like if you need to speak with the medical team, what will you be speaking? What conversation will you be having with the medical team? Yeah. So please, let's open our mic. We need to speak here. So I want to listen to you guys. Please open the mic. I'm listening. Are we still here, please? Hello? Oh, if I'm not speaking to myself. Hello?
Hi.
Yeah. Sorry, are we still here?
Yes, sir.
All right. So this is the question. This is your patient. You are the senior physio in charge. Okay. So you guys are the senior physio in charge. You've been asked, or you've picked up this patient in your caseload. Of course, that is another thing. We don't need to be waiting for doctors. They're prompting us before we do some certain things in the hospital. Anyways, governance diverse, but we need to think about how we need to bring those things back home in Nigeria as well. Anyways, this is this patient here. Either you have been called or you pick them up. This is your patient. How do you treat? Or what do you think? Somebody should speak up, please. There is no right or wrong. It's just clinical discussions. Open the mic.
Can I go ahead?
Please do. Thank you.
Hello?
Hello, go ahead, please.
Okay, sir. I looked at the blood test of the patient. So I'm much concerned with my marker here is my HP, which is 55. So as a senior physiotherapist, before I go ahead to do anything, I'm going to ask for other things, other markers like the platelet level, the result for it. So I will check. I'm going to mobilize this patient, but the sodium is not really a place of concern for me, for her, but this HP. But putting the patient in this context, I will be giving a little mobilization to start up with. That's what I will do, sir.
Before you go, brief questions based on what you said. Are you happy to mobilize with this HB?
No, sir. No, sir. But then for this contest, I won't leave the patient. The HB is 55. So that means it's even a risk for me. But looking at the context of the patient, I think I'll be handling the patient, but lightly.
Okay, you're gonna mobilize them out of bed politely. Okay, that's fine. Let's get another person, please. Let's pick up, guys. Please, let's pick up.
Hello?
Yeah.
Hello? Can you hear me?
Yeah, yes, sir.
Okay, please. I don't know, but looking at the HB, the HB 55. So as a junior physio, I would like to leave it for senior physio to take a second look at it and label it, and also the soil as discussed with some of the medical practitioners, other medical practitioners as well in the medical team. Because the HB is contraindicatory to physio if you want to do so.
Okay, cool. So you won't be taking the risk. That's what you're saying, right?
Yes.
Okay, perfect. And before you go, what does sodium? Does sodium sense anything in your head, correlating it with the patient presentations, or is the blood, other blood parameter? I know you are not worried with other blood parameter, which is cool, perfect. So, but other blood parameter, do they actually pass any message to you as a physio?
Well, the white blood cells are okay. The sodium isn't.
Sorry. I know I'm making it difficult here because I am supposed to be putting the normal value here. I know I've made it difficult for you guys. Sorry about that. Sorry, apologies for that. But because the normal values are meant to be here. But just clinically reason it now. What message are those things passing to you? Those parameters there.
Other parameters, they are okay though. But the hemoglobin is a bit critical.
Okay.
It's below 17.
Okay, fine. Thank you very much for that contributions. Please, I'm going to get 3 more people. Please, let's pick up. Let me see your clinical reasoning. Yeah, go on.
Okay, so looking at the hemoglobin, see the hemoglobin is low, and we've been told that with that level, we have to be very cautious. And as senior PT, you want to make clinical decisions regarding that. Then looking at the creatinine level, it's high. I think that's an inflammatory marker. And you might be looking at there's an infection going on. Considering the patient had a fall and had lung line, that's a given. And the sodium level is 125. That's above the normal range. Okay, Abi? Is it?
Sorry, I've made it difficult.
The sodium level is low.
Yeah.
Okay.
Somebody can just check and pop the normal values in the chat box.
Okay,
Sorry,
so
I'm really difficult. Yeah.
consider leaving. I'm going to consider mobilizing the patient in doing bed exercise with this patient, and if their hemoglobin comes up a little bit, then I'll mobilize. That's
Okay, if I get you right, what you're gonna do is you do bed exercises with them, and when their HB comes up, you can do your mobility. You can get them out of bed. Okay,
yes.
thank you, Pitinka. Yeah, let's get another person on board. Yeah, what do you think? What are your clinical reasonings? You've got this lady on the bed. She's 85. She's got a long life. She had it for the sodium is 125. The CK. You guys are not speaking on CK. I'm not going to tell. CK is 4,000. CRP is 300. White blood cells 40. HB 55. What do you think, physios? What will you be doing? Who are you speaking with? Yeah, please come up. Come up. Mr. Ibrahim, come on board. Yeah. Please come up. Let me read the chat box.
Try.
Yeah. Speak up, please.
Okay. The HB is low.
Okay.
So that means there could be bleeding.
Okay.
Yes, since she had a fall, there could be bleeding. That is this sodium is also low. So that means tolerance, that she doesn't have and low activity as in electrical activity. So that means she may not be able to do much. Exercise tolerance will be very low.
Okay.
So I think just maybe mild, but that hemoglobin, the oxygen level will be very low too for her.
Okay. So you are also worried about this hemoglobin as well. Is that what you're saying, Ma?
Yes, yes.
Okay.
So
Good evening.
Yeah, good evening. Open your mic.
Can I speak?
Yeah, 100%. Yeah.
Okay. Looking at the hemoglobin, it's very low, and based on this class, or based on this teaching, if the hemoglobin is less than 76 or 70, it is critical. So as a junior physiotherapist, I will have to relate to my senior physiotherapist. And as a senior physiotherapist, I would have to discuss also with the medical team, find out what they will be doing about the hemoglobin. Then for the sodium, which is 125, it is very low. I think the number was 135 to 145 according to your slide. So I would need to I would invite an OT. I will work with the OT to help, because it's going to it's going to cause confusion. So they will also assist in helping the patient. Then I think that's it. For creatinine, it's not. You said it's a number. It's not really a red flag.
Yeah. Cool. Good. So with creatinines, what are you thinking about? How could that impact this patient? Oh, she's gone. Okay, 2 more. Oh yeah. Just want to take reactions.
Well done,
Yeah.
sir.
Yes, sir. Well done. Welcome, sir. Yeah.
Can I say something?
Yes, sir.
I just want to say this patient shows signs, based on the marker, this patient shows signs of fatigue and delirium. So we have to be careful. We'll have to invite the OT and talk to the medical doctor about how to mediate the markers. That's just what I want to add.
So are you going to leave him in bed or leave her in bed? Yes, sir.
Actually, based on the CRP, I can wait for another day, because the CRP sometimes can stabilize. So I would like to wait for that inflammatory marker to stabilize, because it's very important when it comes to fatigability. If an ongoing inflammation can cause fatigue, and the patient might not be able to actually actively participate.
Okay, cool. Yeah. Thank you very much, sir. Yeah, let's get another person. Let's get your opinion. One thing sorry, sir, before you speak, one thing that I also want you guys to do is this blood. I have actually bring out some key part of this blood, of blood. Can you guys connect what the patient had with the blood as well. Why is this potassium this? Why is CK this, creatinines? Why, oh, sorry. Why is that? Why is this? Yeah. Pick on, sir. Yeah. Let me have you on board.
Hello, sir.
Hello, sir.
Can I speak?
Yeah, yes, sir.
Okay, so looking at the hemoglobin level, we can say the patient is hemodynamically unstable.
Yeah.
And any exertion can further confuse the patient, correlating with the level of sodium, which will also impair his participation in the therapy. And also, when we look at the creatinine level, the markers definitely indicate that there's ongoing inflammatory process. Therefore, in summary, I can say the hemodynamic status of the patient need to be corrected before I can go on with the treatment. Thank you.
Okay, thank you very much. Any other person? Yeah, good evening. Yeah, I'm reading, please, I'm reading the chat box. You can pop your answer there. I'm reading, I'm also listening to us. Please pick up, guys. Let's have some basic things we need to be doing for our patient. We need to be talking about in our acute settings. Please, let's speak up. No, nobody's right, nobody's wrong. It's just clinical reasonings. It's your reasonings, yeah, it's your opinions, and we need to respect that. So, all right, we just need to correlate whatever we are saying to our patient. That's all, and we should be making the best decision for them. Let me get a few more before I have my opinion as well. Few more guys, speak up.
Good evening, sir.
Yeah, good evening, sir.
Sir, can I go ahead?
Yeah, go ahead, sir.
Speak. Okay, thank you for this wonderful presentation, sir. So what I will say is, in addition to what everyone has said, before I go ahead, supposedly I decided to see the patient. I will discuss with other health professionals to see can they render any helps in case the condition of the patient deteriorates while seeing the patient. So that's what I will add.
Yeah, perfect. I respect that. Perfect, 100%. Speaking with the medical team, even if your patient is fine on the ward, you still have to speak with the medical team. Normally, what I do, nurses are always with the patient at the bedside. Speak with them. Oh, how is this man today? How is this lady today? How are they doing? How are they presenting? Are they interacting well? Are they eating well? Are they drinking well? Your nurses are your friends. Doctors are your friends. We shouldn't. For you to be an excellent doctor in acute hospital, you need me. For me to be a good physios in an acute setting, I need you as well. So we are friends. We should be friends. I should not be fighting you. You should not be fighting me. For us to make a best decision for the patient, we should be friends. So speak with the patient. So thank you very much for that input. Speak with your patient. Speak with the nursing staff. Speak with the medical team. Oh, if this patient deteriorates, is there any escalation plan? What are you guys thinking? Speaking with them, it shows you know what you're doing. Yeah. All right, few more guys. Speak up. Let's get clinical reasonings. Yeah, speak up, please. I'm not worried if I can't run the ABG today. I'm not worried, but we need to track this down. Yeah. Hello. Hello. Yeah. Hello, we're listening to you. Hello, we're speaking.
Is grandma upstairs? Yes, she's downstairs. That time they was Oh, not upstairs.
Hello. It seems nobody is speaking again. All right. Maybe I just go ahead to share my opinion. One thing I'm going to tell us today is please always put your patient presentation into context or whatever blood interpretations you want to do. Let me say that again. If you need to reinterpret patient blood, put that blood in the context of your patient. That is very, very key. I cannot, it will be very wrong for me to just sit down in my office, crossing my legs, looking at patient blood chart. Yeah, you can make an assumption. Oh, this is this, this is this, this is this. Yeah, but their sodium is really, really very low. They're gonna be confused. They must be confused. It's not absolute. The fact that their sodium is very low does not mean, yeah, they must. They can be confused. Get me right. They may be confused, but it's not absolute. So you need to put that in the context of your patient. Same thing for everything. Yeah, this lady here, she had a fall. She had a long lie. Sodium, if we go back to the value, I think it's low. Sodium is low. So why is the sodium low, first of all? That is the question we need to ask ourselves. Why? I explained why making those explanations. Why is the sodium low? Oh, will it be that when she had a fall, because she's been in bed now, she's a poorly woman, she's been in the bed, she's not eating, she's not drinking well. Is it because of dehydration? That question should strike something in your head. You're a physio. That should strike something in your head. Oh, could it be that she's dehydrated? Could it be because of that? Could it be that causing her sodium to be low? Or could it be because of infections? Infections going on. Now she now got chest infections. She's got this going on, infection going on. Could it be because of that? And what does that mean to you as a physio? What does it mean? Sodium low. Well, I may say, yeah, this sodium, I will not be absolute. This sodium may be confused. So I will need to see them first of all, or while reading the medical note, there could be some area in the medical note that are saying the patient is confused, they are delirious on the ward, or the nursing nurse is saying they are delirious, they are confused, they are inattentive, they are struggling. I don't know if we document all of these things in Nigeria. I don't know. I don't really know. I've forgotten, honestly. But these are something that needs to be documented. Are they confused? Are they disoriented? Are we going to their bedside? So now, and again, even if I don't pick those things up in the medical note, when I get to their bedside, I need to investigate them as a physio. How do I investigate? And I just do a quick 480, or I will do a quick 480 with them, or do orientation test with them, 4MT or whatever you want to do. Oh, what does that mean? I might say, oh, can you confirm your date of birth? I don't know. Depending, you can use your local dialect to ask them those questions. Ask them, can you confirm your date of birth? How old are you? How old does that make you? Ask them those questions. Do you know where you are? There are a lot of our people in the world that are confused. We don't even ask them those things. We don't know. We need to ask them, do you know what facility are you in today? You need to ask them, what area is this? What was this? Ask them those questions. Are they aware? You need to ask them. The other part of the 480 could be asking them to do month of the year from December backward. I know that might be difficult for some of our patients in Nigeria, depending on their level of education also. But you can ask them, just ask them orientation question to know, is this person really orientated? And from the look, why are you actually asking somebody to do December backward? It's just to get their attention. Because for you to be, it's difficult, even for normal person. If I ask you now, if I just call somebody on the call and say, okay, do December backward for me, recite the month of the year from December backward. It's going to be challenging to you. You need to be attentive to be able to do that. December, November, this, and down to January. So you need your patient to be attentive to be able to do that. That is what we are testing. And if they can't do that, there is a score for it on 480. These are evidence-based stuff we need to be using for our patient in acute hospitals. Are we using those things? Big questions. Big questions for us to answer. All right. So that is just by the way. Sodium, you know where sodium is coming from. Oh, yeah, sodium. Yeah, CK, creatinines, where is that coming from? This is somebody that have fallen. They are in bed for longer period of time. They are in the floor for longer period of time. They are not eating. They are not drinking. Or elderly patients, they've had reduced oral intakes. They drink less these days. They eat less these days. Where is that coming from? And they are not moving. What does that mean? Their muscles might be breaking down. There's a term they call rhabdomyolysis. Rhabdomyolysis. It's just muscle breaking down. And what does that mean? That is creatinines now. Creatinines are being released. Now, creatinines now going up. Could be like in acute hospitals. They will start, oh, I think this might be maybe acute type 1, AKI1, acute kidney infections, early stage. Because creatinines are going high because it's not eating well. You can see reasons why you need to be doing early interventions with patients. Our patients we are not seeing on those wards that are quickly healed, that are being poorly, and we are not doing stuff with them. They are dying because of some of these things. I am telling you honestly, that those things that are being done in the West here are actually adding good quality life to their life. The thing is, you will look at some patient case load here, honestly speaking, you will find the patient with 10 comorbidities, and they are still living. They are driving, 80-year-old man driving on the road. What are you saying? So we need to be acutely involved. If you really want, I know our health system is really very complex, but if we really want us people to really respect us, we need to show capacity in acute hospitals. How many of our people, how many of other MDTs are coming to our outpatient? Do they really know what we are doing there? Where you can really show capacity is acute hospitals. Honestly, patient on renal dialysis, get them up, get them moving. In UK, yeah, before you know, you will see medically fit. Why? Because physio has intervened. Before you know, they are able again. They are very okay again. Why? Because we have intervened. We need intervention. Anyways, CKD, where is it coming from? Their muscle is breaking down. Their CK is going high up. This is where it's coming from. They are dehydrated. CRP, infection has entered. We don't know. CRP, like non-specific, like I mentioned, we don't really know where the infection is coming from. It's not being specific, but we know CRP is high. Yeah. Infection going on. White blood cell infections. I think it's high. I don't even have those things in my head. I don't have reason to put them in my head. I think it's high too. Oh, white blood cell infection going on. We don't know what type of infection. I don't care. Even if you don't know, it's none of my business. What discussion I can just have with the medical team is, I can just ask them, are you guys doing something now? The white blood, I just look at the white blood cell. White blood cell is being high. Are you guys doing something on that? Yeah, because I'm thinking, if they are able, I can still do my stuff with them. These are discussions you should be having with the medical team. They are not your enemies. That is the essence of this webinar we are doing. Nobody is your enemy in acute hospitals. Your patient care should be our ultimate priorities. We need to start thinking in that lane. That is the essence, or that is even part of the reasons why we are here today having this discussion. Anyways, let's move forward. HB 55. This is too low for me to do stuff. Don't forget, less than 70, they are likely for blood transfusions. We are all right. HB is steadily here. HB is low. This patient who is going to be really, really very poorly in bed. Their HB is just too low. It's just too low. They're going to be very, very poorly. The only reasons why I can then think about, okay, then I can then physios, go back to their past medical histories. Is there something you can pick up that you can link back to their HB? Are they normally chronic anemia? Do they even have maybe chronic kidney disease? Normally, even if they have chronic kidney disease, I would not be happy to do stuff with patients with HB of 55. I mean, I would not be happy to do that. It's too low for me. It's too dangerously low for me to do that. It's dangerously low for you to do stuff with them. So now you might need to, what will you do next? Speak with the medical team, speak with the consultant in charge, look at the medical notes. Are they for blood transfusions? Look at those things. But generally here, remove the HB from this patient here. Honestly speaking, white blood cells, CRP, CK, I'm not too worried from my perspective to do stuff with them. Yeah, somebody spoke about because of their infection marker, they can have low endurance, they can have low exercise tolerance. If their hopes are fine, like if their new scores are fine, what am I saying? If their blood pressure, heart rate, temperatures are fine. Because of this ongoing infection, I know their temperature can be slightly high. If they are on good antibiotics, their heart rate, blood pressure can even be stable. All this white blood cell alone, CRP alone is not enough for me to say I'm not going to do stuff with this patient. Come down here, you will see a lot of CRP being very, very deranged, high number. See, white blood cell, high number. I'm not worried. Do your stuff. Just grade your approach with them, because we know you guys have said it, because their endurance can be very poor. Think about progressing them. Oh, if you are for mobility now, for mobility progression, lying to sitting, if it is that what you can achieve in the first day, that's okay, but not with this HB anyways. Not with this HB. This HB is low. In this particular patient, what I'm going to tell you is, I'm not going to see this patient for mobility for rehab because of this HB here, and I will be needing to speak with the medical team. They need to do something. They need to intervene. This patient might be for blood transfusion. As soon as the blood is okay, the HB is fine, start doing your stuff. And for your sodium as well, with your 480 that you did, or with the 4MT that you did, your normal orientation that you did with the patient on the ward, or if you sense that they are confused, get your OT colleagues. Our OT needs to be retrained for them to be able to do some of this stuff on the ward. Get them involved. Let them start coming in. Let them start seeing how they can progress your patient in terms of their cognition. All right, that's that on these questions. I'm not sure we can still be able to run the ABGs today. It could be that maybe we'll run that in some other class. So I will just leave us today to go back, have your reflections, please. And I'm happy if we can. It's not necessary for you guys to put your name on it. Write a reflection. You can send it on page. Let's see what have you learned, or if there are any further questions, pop it on that page. I'm also on the page. We can have discussion. The goal is for us to add the rudiment. All these things we've been discussing so far, honestly speaking, believe me, these are the bases, like the rudimentary things we need to know when it comes to working with patients in acute hospital. These are basic things, honestly speaking. So please, I will encourage us. One good culture that the West are using for when it comes to learning is reflections. Please sit down, pick a pen, pick a pen and a book. Have a reflections. What did I learn today? What am I going to change in my practice? What am I going to change? What next I go on the ward? What am I going to check? Have a reflection on these things. That is how to demonstrate that you are actually learning, and you are putting your patient at the center of everything that you are doing. So before we close, let me have some questions. So I will just keep ABG for now. It could be that maybe in the next sessions I will just quickly run through the ABGs and then do the plan work for that day. So let me stop here today. Thank you very much, everyone. Thank you for listening. So I'll be here. So if there are questions, then let's take those questions before we close. Thank you. The moderator, sir.
Question.
All right, go ahead.
How long pre and post transfusion is appropriate to mobilize a patient? At my workplace, we use this protocol of 24 hours. You are not supposed to mobilize a patient 24 hours before transfusion and after transfusion. So I'd like to know.
All right, thank you very much. Protocols is protocols. And I want to assume before people sit down and bring up those protocols, they might have seen protocols are product of, when you say evidence-based are product of, what is it called? What does the literature says? What is the expert experienced? Your patient too as well, putting your patient in the context. I think evidence-based is three-legged like that. So I want to assume before people have come up with protocols, these are consultants, these are senior physios that have sat down, to sit down, bring knowledge together to come up with those protocols. If that is what is obtainable in your setting, please stick to that. Stick to that protocol. That's fine. But generally speaking, for a physios, let's say for example now for this lady, I'm worried for HB of 55. I don't want to do stuff. And I just document in that note, patient not appropriate for therapy intervention because of their HB. Are we putting all of these things? Or do you just say, I'm not documenting because I didn't see them? Oh my God. You can be weak. It doesn't work that way. Do your documentation. When you don't still see them, put it there. Why don't you see them? Justify the reasons there. So put your documentation there. And after that, so you need to, before you see them generally, you need to see their post-op blood. They need to run another blood after they transfuse them. I mean, no post-op now, after like post-transfusion blood. They need to run, the doctor will run another post-transfusion blood. What am I saying? The doctor will run another blood test after the blood transfusion. So you may need, when you come down again to see them, then you can then check those tests. What's the readings then? If your protocol then says, even if their blood is stable after the blood transfusion, don't move them. Stick to that. That is no concern with that. Stick with your protocols. That's okay. But generally, if their blood is fine after transfusions, their HB is now 80. Oh my God, let's do physios. That's it. That's it. Hope I have answered your questions.
Yeah, thank you.
Thank you very much. Yeah.
So I have a question.
Yes, ma.
Okay, my question is in the cardiac markers, when you talked about the D-dimer, and I know that this is one of the major tests we use to run for our DVT patients, and you said we can go ahead and do everything. Now, my question is, now for a patient who has GBS, and there is a suspect that this patient came down with DVT, and when the D-dimer test came out to show that it was higher than the normal value. So my question here is that since you said we can go ahead, these are not the major markers for us, so we can go ahead and do a rehab. Should I go ahead and mobilize this particular patient?
Okay. Yeah, thank you very much for that question. Brilliant questions, clinically sound questions. I love the questions. Now, D-dimer. If there is a suspect that, oh, this person might have a DVT, they run the test, D-dimer is deranged, the D-dimer is high. Yeah, that's confirmed. Or now, even not still, yeah, that could be even though it could be a confirmed, but generally speaking, for you to confirm that somebody has got DVT, you need a Doppler ultrasound to confirm actually. But D-dimer can still give you a clue. In some hospitals, they do web scores, something like that. Yeah. So, but generally, if that is what is being obtainable in your hospital, what I'm going to tell you is, of course, at that moment, no physios. That was what I said. No physios at that moment. But if you need to do stuff after their post-diagnosis of DVT, generally speaking, what the guidelines recommend is before you do your physios, that patient must be on appropriate anticoagulant. That patient must be on enoxaparin, which we call clexane in Nigeria. You need to check their drug chart and you ensure that your patient is on treatment dose. That is how it works. Generally speaking, let's say a patient in acute hospital, patient has been admitted in the hospital, they are being poorly, they are not being mobile. Medical team will put them on what's it called now? Therapeutic dose for clexane, just to prevent blood clotting in their legs. Now, if I not check their drug chart, they've been recently diagnosed to have DVT, and they are still on the treatment dose, I'm not going to move them. They should be on appropriate dose. I'm sorry, they are still on therapeutic dose. Therapeutic dose is just dosage of medication. I'm going to speak about drug, don't worry. There are dosage of medication that are used to prevent blood clotting. Like, in the context of DVT now, blood clotting, for example now. Let's say they are on, 10 milligram now, for example, for the treatment dose before DVT, before they diagnose DVT. Now, after DVT, 10 milligram, I'm not going to move them. As a physio, what are you going to do? You're going to have to go speak with the medical team. That is why we need to have knowledge of blood as well. Oh, this is patient, you guys just recently diagnosed of DVT. What are you guys doing? I look at their blood chart. I see it. I know these are conversations that are difficult in Nigeria because of our egos and stuff. But that we need to be thinking positively. We need to be, because doctor can feel like, why are you having this conversation? But it is obtainable here anyway. But with time, we pray we get to that level as well. But let's teach normal thing now. No, normal thing. You can speak with him. Oh, what are you guys doing? But don't be affirmative. Ask him, because there could be some reasons why they are not putting the patient on there. Don't be affirmative. Just, there's something. I'm just wondering, because I just look onto his drug chart and I see that this patient is still having 10 milligrams. Why is it? Oh, no. What are you guys doing? Because I'm worried with my physio. Put it in your physio. You are not a medical doctor. You are a physio. Don't be affirmative. Don't be affirmative, because I'm just being worried. Is that okay for me to mobilize them? That's how you put your statement. Is that okay for me to mobilize? Then they can say, oh yeah, this is why we've not actually put them on. It could be three things are involved. It could be, we didn't actually want to get him, increase this dosage because of these social reasons. It could be because, it is doctor, this that should be doing that. I don't know why it's not done that. It could be because of that. It could be because, no problem. There's this. They can give you any response to that. But before you do stuff, if they are saying your patient is fine, go and do your stuff, get them to document. Get the person to document. And when you are also doing your own documentation, put the doctor's name there. Ask for his name. Oh, yeah, doctor, doctor what? Then put his name there. Doctor, this patient is free. But generally, again, you still need, because you are autonomous practitioner. The fact that they have mentioned, they have mentioned that this is a DVT patient, it's not an appropriate medication, I would say generally don't do it. Even if they have mentioned to you to do it, I would say generally don't do it. Because what national guidelines anywhere in the world recommend is, at least before you do something, keep it after 24 hours. And they have to be on appropriate treatment dose, not therapeutic dose, treatment dose for you to do your stuff with them. In some settings, you might find it as after 2 days. If in your settings, your protocol is after 2 days, do it after 2 days. As simple as that. But if after 2 days, you are not getting your patient out of bed, you are endangering the life of a patient. That is as simple as that. Because anywhere in the world, after 2 days, max, you should be doing your stuff with them. There is no contraindication with it. The GBS has no correlations. Even with GBS, is more reason why you need to see them. Why you need to see them. With the GBS they've got. With the GBS, it means they've got ascending motor paralysis. What that means is this patient might be breathing less. If you are not treating them, you are not getting them out of bed. They might start retaining CO2. Before you know, respiratory failures, type 2 respiratory failures. More reason why you need to see them. That's it. So they can pass, they can die because of that if you are not seeing them. So more reason why you need to see them is because of that, even that GBS. 2 days max, treatment dose, normal treatment, treatment dose for medication, get them out of bed, no contraindications. Thank you. Questions? Did I answer your question, Ma?
Yes, you did, sir. Thank you.
Thank you, thank you. Yeah, questions. And that's why I'm not running the ABGs today. Questions. Let me check the chat box. We are not asking questions, guys. Okay. Moderator, sir. Hello, sir. I don't think there are a few more questions, so maybe.
Excuse me, Dr. Lagoke.
Can you hear me now?
Hello, sir.
Okay.
Hello, Dr. Lagoke.
Okay, so it's simple to ask the question, right?
Hello, sir. I can hear you.
Okay. Yes, I just wanted to say thank you so much for what you have done, opening our eyes to a number of things. Thank you so much. 2 things, actually. Number one, you mentioned a lot about junior ones reaching out to the senior ones on some matters. I'm happy that I had Chioma mentioning that I will reach out to my senior colleague. That's a very good one, but I think it's very important for us to know what are those markers that we are looking at, use the clinical reasoning. Even if we are reaching out, at least we'll continue to build capacity so that at some point we are the ones that will become the elders, and then we'll be able to guide others. And then to those ones that are seen as seniors, I think it's important for us to now review our practice to be able to see that are these things truly part of our practice? Can we guide the younger ones so that then that's a good thing. But if not, then let's begin to find ways to upgrade ourselves so that we can be able to face that responsibility that is on us. Then finally, you have talked a lot about escalation from the context of referral. But I want to talk about escalation now from the context of stepping down. It's very important for those that are conversant with this area to be able to, especially now that we are having more information coming and we are rubbing minds, and we need to begin to step down to others. So I will appreciate if those that have experience in this area, added with what we are going to gain from this workshop, that reach out to us so that we can now begin to render workshops all across the country so that everyone in every hospital that is involved in acute care can be able to understand these concepts and begin to practice them. Thank you so much, Mr. Olaroke. I truly appreciate you. And as I've said, please let this not be the last training that we'll have this series. If you have any other thing that you want to train us on, to just let us know, so that after this, even with your start schedule, just let us know, even if it's next year, that we schedule another one so that we continue to learn from you. Thank you so much.
Yeah, very interesting. Kawai dai mu tayin ilimi da aka yi mana da shi. Mata da yawa mutanen mu su sai ana kitchen.
Hello, Dr. Lagoke.
Hello, sir.
Yes, sir. Thank you for this lecture. I typed a reflection and I want your opinion on it. I've learned a lot of biomarkers today, and my reflection is that irrespective of the results, the laboratory results, one should just stay calm and look at the clinical presentation of the patients. That the clinical presentation of the patient, should serve as a guide to the physiotherapist on what can be done while we address the derailment by discussing it with the appropriate personnel that we address the derailment, that no patient should just be left unattended to, irrespective of the biomarker results.
Yeah.
So that's my reflection. Is he okay, or you have a contrary view to that?
Sir, perfect, 100%. Thank you very much for that clinical reflections. Honestly, that's what we've been talking. So put everything in the context of your patient, adapt their blood values to your patient. Every guidelines, every protocols, every skills, every clinical skills, every clinical knowledge should be adapted to the patient, because no two patients are no two patients are the same. So thank you very much for that. That was a very, very brilliant clinical reflection. It's not about knowing a lot of stuff, and in the end, you go in to do stuff with your patient and you endanger their life. So it's just about you thinking about them. Oh, what have they got? You might find somebody, everything, blood, everything okay, and they will still be poorly in bed. So it's about you looking at your patient. What do I need to do? And again, don't forget, patient is at the center. In fact, one of those things I normally encourage my juniors over here to do when they go see a patient is you need to understand the perspective of your patient. If you don't understand, especially in the West, you might just leave their bedside, and before you know, they can escalate to PALS, they can escalate to anybody, they can even charge you to court. You need to understand what they want. And I think we need to start bringing that idea down to Nigeria as well. We need to think about managing our patient expectations. I normally tell my junior colleagues, patient is the center here, no matter the skills you've got. Ask your patient, try to understand the impressions, their understanding of their conditions, their concerns. What are they concerned with? There are some patients, they've got back pain, they've got pain in their back. Some patients are not even concerned with the pain. And you think you just go to their bedside, you start doing pain stuff with them. That's not even their concern. Their concern could be, oh, they want to still be able to go to their farm, they want to still be able to go to their work. So your therapy goal should be in accordance with what they want, their concerns. And again, there are some patients that also have some unrealistic expectations. And you may need to bring in your therapy skills to be able to get them to be aware of what is going on, bring the reality closer to them. There are some patients, it might be because of confusion, it might be because they don't have capacity, it might be because they have poor understanding of what is going on. And this, I don't know, this old way of treating patients, you don't want your patient to know what you are doing for them, is archaic, is old. Treatment, what's it called? Medicine has shifted from being paternalistic now to patient. Everything is patient. Whatever your patient wants is what you want. If you go to their bedside to see them and they say, no, I don't do physio today, they expect that decision. You just need to ask them, why are you not doing physios? You want to just persuade them, encourage them, tell them why physio is important, but you can't force physio on them. Same thing with medical treatment. If the patient is saying no, no is no. No is no. So we need to start respecting patient perspective. Everything we are doing in acute settings, in acute hospitals, or patient-related stuff, everything needs to be adapted to our patient. Thank you very much once again for that good reflection. Thank you very much. God bless you. Thank you very much, sir. Yeah. Hands are up now. Mr. Chigos, I don't know how to pronounce the name. I'm sorry. Chidoke. Yeah, Mr. Chidoke.
Yes, thank you very much, sir. Thank you very much for the insightful lecture. I wanted to ask a question. You mentioned low platelet count. That is I think that should be thrombocytopenia. So I wanted to share an experience I had. That was during my internship days. There was a
Go ahead,
patient
sir.
that,
Yeah.
yeah, there was a patient that I was invited to Clark. Physio was invited to Clark and and treat and all of that. And I went to go see the patient. And during the assessment, I looked through the patient's folder and I saw that this patient, it was documented that she had thrombocytopenia. So at the time, I didn't really see so much of the clinical relevance of that to my management. But I tried to look it up, and then I noticed that there were some issues with that could affect my management plan. Um, when it comes to manual therapy, massage and all of that, I just looked through and I found out it was contraindicated. So my question is, I was able to follow through. I was able to avoid certain things, certain considerations, avoid manual, too much like high pressure manual contact for her, and all of that. So my question is not just a question. It will first be like this, a recommendation part of it, and that is for us to be able to like quickly look through stuff that we don't understand, and then possibly flag it up with other colleagues, because you could know something, and then you're, because here it's not like you know, the same person is going to keep seeing the same patient over time, you know, so different people are going to have to see the patient, and sometimes it's not really so monitored. So the best will be to like be able to document those things properly and flag it up to other colleagues, and maybe find extra ways to communicate that, maybe through WhatsApp groups or something, that this patient needs to be, you know, we need to take extra caution. Then my question here would be, for something like that, for thrombocytopenia, what are other considerations in terms of manual therapy and, you know, and exercise and your general physio? Are there like other considerations that, you know, we need to look forward to? I think maybe you've mentioned it. I don't really remember. But are there other considerations that we need to put in place, that we need to keep at the back of our heads while attending to such a population? Thank you very much.
Thank you very much, and thank you for sharing your experience as well. Clinical experiences are, you know, different, and, you know, coming on board to share those experiences, it really matters a lot. So and again, well done. You did the right thing. You saw it. You quickly look it up. You quickly avoid it because you know the implications, and again, you flag it up. Being able to put excellent conversation, documentation as well, is also very important. And again, getting your colleagues to be aware of that, getting other MDT to be aware of that. Oh my God, you've done a brilliant job. Well done, well done for that. Thank you, and thank you for taking good care of your patient as well. So now, in answering the questions, I mentioned that time that when a platelet is deranged, especially when a platelet is very low, the patient is at risk of bleeding. Bleeding might not really be, we can see physical blood outside. It could be internal bleedings. It could be GI bleedings. It could be, some patient can have a brain bleed. Some patient can have thoracic bleed. Some patient, it could be bleeding anywhere else in their body. So now what we just need to do as a physio is, sometimes, I mentioned the other time that if platelet is less than 50, don't do it. But if you've got clinical reasons why you need to do it, of course, the decision must be made by senior physios. And again, put it in the context of your patient. If your patient is at risk of fall, for example, you don't want to do it. And again, let's say you want to do chest physios. They are really chesty now. You want to see them from chest point of view now. You know you're going to do manual techniques. If you overclap them, if you overdo your mark, if you overdo your percussions, you can make them internal bleeds. You can cause an internal bleed. What that means is their bleed even without you doing stuff with them, with low age platelet, their patient can bleed spontaneously. Like they can just bleed on their own without even you doing stuff. I've seen some patients like that. Some patients can start bleeding on their own. You will see patient on the chair, low platelet, they'll start bleeding from the nose. These are experience on acute settings. Some might start bleeding from the nose. So that is to tell you that we don't also take platelet for granted. But if you really want to do stuff, let's say chest, now you want to see them from chest point of view, you will need to grade whatever you want to do with them. And again, put it in the context of that patient. How are they presenting in bed? Are they presenting really very poorly in bed? Are they frail in bed? A platelet of 20 for a frail patient in bed, and you are saying, they are chesty, and you are clapping their chest. You may be causing them more harm. You may be causing them more harm. So put that in the context of your patient. And aside from that, the other thing I'm going to tell is, speaking with MDT, oh my God, it cannot be overemphasized. Nobody is our enemy. For patient care, nobody is your enemy. Speak with the MDT. What I normally do, I can be on another ward, my band 5 here, junior colleague, they can just quickly run to you and say, Sheriff, I've got this patient. The platelet is I've mentioned to you, when you are making conversation, even with your colleague, even with other MD, don't be affirmative. What do you think? Do you think that is right? Don't say it's not right. You are not making this. Don't be affirmative in patient care, because there are a lot of this. The fact that it is slow does not mean you can still not do stuff. You really need to do it. Don't be affirmative. These are one of those things we need to take away from this clinical discussion we are making. So just say, oh, I've had the patient that they will say, I've had the patient that well, their platelet is, do we really think is right? Or I don't think I can see them. Don't say I cannot see them. That's wrong. I don't really see them. What do you think? I will say, okay, what's their name? Let me go read their notes. I'll go down. But if I really need to see them, let's say from chest point of view now, what I'm gonna do is when I get to their bed, I will screen the medical note. Is there any bleeding, anywhere, GI, upper GI, brain bleed, anything? Check their diagnostic device, check their CT, check everything. And when I get to their bedside, I will have conversation with the nursing staff. Nurses are with this patient. I will ask them, oh, hello, what do you think? I'm coming to see this patient. Are they fine? How are they presenting today? Oh, I just look at the notes. The platelet is really, really low. I'm not really very happy, but because they've got really bad chest infections, so I might just want to really just do some stuff with them. I might just ask them, so is there any bleeds anywhere? Ask them that questions. Or are they bleeding? Is there any concern with bleeding anywhere? Ask them. And if it is doctor you see on the ward, have that discussion. I'm just worried with this platelet. What do you think? Because chronically, that might be their baseline. You can even find out that 40 is their baselines of platelet. And if you are not, and they've got really chest bath infection in bed, and you don't want to do that, oh my God, that's the wrong decision for your patient. If that is their baseline of platelet. So you may also want to speak with the medical team. The medical can then say, oh yeah, we've been treating now. I think I've gone through the medical note. We've been treating them for a while now. So that is their baseline of platelet. Oh, that's fine for you then. Go ahead. And again, just that you might just need to go, oh yeah, for somebody to have this kind of platelet that is baseline. Oh yeah, I might just need to do that. What it means, clinical reasons. That's what it means for me. So why would just say platelets, bleeding? If you need to do invasive therapy like suctioning, like I know we are gradually bringing those things down to Nigeria now. So positive pressure, all of those things. If you really need to do those things with your patient, these are invasive techniques. So you know any small thing, any puncture, anything can make them bleed. Chest physio, you want to be worried. Rehab, you want to be worried. Let's say my patient now, they are not for platelet transfusion. The medical team has said, they are not for platelet transfusion, and we're happy with the medical. I will just say to you, just document for me, document that. And I also put their name in the medical notes. That's all. That's all. So did I answer the questions, Dr. Chigoze? I don't know how to pronounce the name, I'm sorry. Yeah, that's it. Right. Did I answer your questions, or are there any further questions? Okay.
Good evening, sir.
Good evening, sir.
Hello.
Yes, sir.
Hello, sir.
Yes. Thank you for the presentation. Thank you for the workshop. I think I've learned so much in such a limited amount of time. I just want to ask, are we going to get the recordings for this?
I think I might not be able to. I think I might not be able to answer that. I think the organizers will be in the best positions to answer that. So I don't know, honestly. I don't know. But what I'm planning actually is I'm going to actually see if I can put all of these things together in a kind of like handout, or what do you call it, workbook, that I could just try to put them together and send it to the page, because we just need people in Nigeria to be aware of all of these things. We need to know all of these things. Honestly, I will take that up and I'm going to put it in writings, just short things. Why are you doing this? This is why you are doing this. This. And I will send it to the page. By the grace of God, I will try to do that. Yeah. But I'm not sure about the recordings. I'm not very sure. Yeah.
Oh, okay, sir. Thank you, sir.
Yeah. All right. Yeah. Okay. Can we have a few more questions before we close the meetings? Yeah. Come up with your questions. You can come share your reflections. That's fine. If you want to share your reflection with us, what you have learned, what you're going to do better in your practice, or what you think might be challenging where you work. Yeah, what you think, bringing those knowledge down to where you work, you are working, how challenging it could be. Bring up, come, let us know. Yeah, come up, come share. So I think our people are having iftar now. The Muslims are breaking. All right, so I think it's high time. Yeah, oh yeah, your hand is up again. Yeah, open the mic, sir.
Okay, thank you, sir.
Yes, sir.
Can you hear me now?
Yeah, audibly well.
Okay, thank you, sir. So I wanted to express a concern.
Hmm.
And that is the fact that sometimes the average setting or the average facility that we are practicing in, there may not be so much time to given to actually think through patients cases like this. A lot of times the pressure is much, especially when you have to see, I mean, one physio is left to see like 4 patients in the ward or 5 patients in the ward, still seeing patients on outpatients, and the system is moving really really fast. So that's the concern that I'm presenting. Of course, it's going to be difficult to say that the patient load per physio should be limited. But what are the steps that we can take to circumvent, this time factor? What are the steps that we can take in our facilities to ensure that we can still ensure efficiency without, without burning out?
Yeah, thank you very much. You see why we need to be talking. Thank you very much. Appreciate that. Yeah. So now, yeah, I understand pressure. One physio is in one big facility running inpatient and outpatient facilities. Pressure is everywhere in the world. Even here in UK. Oh my God, my team now, we cover, I think, a lot of wards, almost 15 wards. We cover renal, we cover gastro, we cover head and neck, vasculars, and all of those things. So ITU. So you'll be on bleep. This one, doctor will be bleeping you, nurses will be bleeping. Pressure is everywhere. So one thing that and again, let me say this clearly: the fact that there is no lot of pressure on you. In fact, in the job descriptions, what is normally written there is somebody that can work under pressure. That is what is written there. Physio can never be enough anywhere in the world. Physio can never, because our work is so vital. Physio can never be enough. That is the reality here. Now, the fact that there is no lot of pressure on you or on me or on that man as a physios does not mean that you should endanger the life of somebody. The fact that there is pressure on me does not mean these are rudiments. Anytime in acute settings, I need to go see patient. I need to read their case notes. I have never met this man on that ward, on that head and neck ward, ENT wards, gastro wards. I've never met them before. I've never seen them in my life. So I need to read the medical notes. I need to see what the medical teams have been doing with them. I need to understand their life journey, their health journey. I need to know what they've been doing with the nursing staff on the ward, what dietitians have been doing with them, what the speech and language therapists have been doing with them, what the OTs, if they've been seen by OTs, what they've been doing with them. I need to read through their notes to understand their journey. And again, before I then go in now, I've read the recent medical note. Oh yeah, this is what the medical team are doing. I'm not concerned with whatever they are doing with them. Cool. Then I will then go back to the blood. We need to look at the blood. If the potassium, like I mentioned the other time, one of the great killer of patient in acute settings is potassium. This potassium go crazy. If you go in to do your stuff, you might make them to die. So check their potassium, check their HB. If you don't really have the time, check that. Already know what you are looking at. Check their potassium, check their HB, check their high check their blood platelets. If those things are fine, those 4 things are fine. Roughly, if like there is no concern with DVTs, other big red flags, so I won't be worried about other things. I can then go into them. Then how do we resolve the issues of pressure? It's as simple as prioritization. Prioritize your patient. Honestly speaking, you don't want to be spending time when you've got an acutely unwell patient, they are dying, they are chesty, they need your interventions, and you've got somebody on a patient ward for rehabilitation. I know they've come to the hospitals, they spend their monies. I know the Nigerian factor, they've spent their money, blah, blah, blah. But you've got somebody on the ward dying, and you are the only physio on board. Who do you see first? We need to prioritize. This is where prioritization comes into place. In acute settings, your prioritization skills need to be top-notch. You need to be top-notch in acute settings, but there's going to be pressure on you. How do you prioritize? Here in the UK, where I work, generally you see people prioritizing chest first, because they can die of respiratory failure. Nobody can fix respiratory failure. Nobody, not even a doctor. They need physio. So they're going to die of respiratory failure. I need chest physio to be seen. I need discharge to be seen. This is UK. Let's talk about UK. Put it in the Nigerian context. Who do I see first? Generally, if I have, let's say I have 3 patients to see on the ward, I've got 3 patients in different wards to see. I need to look at their case. The difficult part again is we are still using paper stuff in Nigeria. It's not like where I can just sit down somewhere, assess their caseload, read patient in ward 32, patient on ward 50. When I do not actually need to start, climb up before I go see them, or I do not actually need to work 30 minutes, 40 minutes before I get access to their caseload. But then it is what it is. But I think what we just need to do is just prioritizations. If I go down to read their caseload, let's say 30 minutes, and I say that this patient are actually doing well. Let me just say this thing clearly again. Mobilizing patients is not just physio duty. In fact, it's part of the scope of practice for the nursing staff as well. Nurses can actually mobilize patients. Let's say I'm reading through their note as well. I'm going to talk about this thing later on, don't worry. Let's say I'm reading through their caseload and I see that they've been doing stuff with the nursing staff. They are not acutely deteriorating. And I've got somebody somewhere that is acutely deteriorating. And the first one is just for normal rehab, progression, mobility progression. I will drop them, see the one deteriorating first. So all we just need to do is prioritize. Even in outpatient settings, I know our prioritization in Nigeria is based on first come, first serve. But ideally, let's imagine we've got 30 patients now, they're on grant, and you just walked in as a young guy, young physio now. Ideally, I know we do it according to their first come, first serve, but how should we actually be prioritized? It should be according to the patient presentation, like patient presentations. Because patients you are meant to see 10 minutes. If you don't see them 10 minutes, they can die. So it's just prioritizations. I don't know if that answers your questions. And speaking with the right person, speaking with the medical team, know what you need. Oh, nursing staff, I go on the ward, I know their platelet is deranged already. I can just say, oh, are they bleeding? Have you seen them before? Oh, yeah. Have you seen them this morning? And the nurse can, yeah, they are bleeding. Just leave them. You know, that patient is already off your caseload. All you just need to do later in the day is just to document. That's all. So know who you are speaking with and be very clear in your discussion. Know why you are having certain discussion. Not, I just want to speak with the doctor, and you stand in front of the doctor, you don't even know what you want to speak to him. It does not make sense. It ridicules you as a physio. Know the conversation you want to actually have with him. And once you have that direct conversation and you see this is red flag, just leave the patient, document, go away, go and spend time with the other one. I think one of the ways we can use in acute settings, excellent communications, know what you want to be communicating, and your prioritization. I think the key things here is just prioritization. Thank you. What do you think, sir? Does that make sense? Oh, yeah.
Yes, sir. Yes, sir. Absolutely. Thank you so much. Thank you so much, sir.
Thank you. Yeah. All right. Guys, ladies and gentlemen, I think I'll be stopping here today. Thank you, sir. Thank you, Professor Rufai. Thank you for this opportunity. Thank you, everyone, for joining. And I know we still got a lot of questions, but I may not be able to take them because it seems like I'm tired as well. So, but please on the group page, so we can pop in our questions, we can pop in our reflections, we can pop in difficulties we might encounter in our different place of work. I am happy to read through them. I am happy to add my opinion on it. So that's it. All right. Thank you very much. So I'm going to catch up with you guys next time. All right.
Thank you. Well done.
Thank you for your time and the explicit lecture.
Thank you very much, sir. It was very, very stimulating and exciting.
Thank you very much, sir.
All right, good evening, everyone. Sorry, I just realized that the registrar is no longer in the meeting. Thank you so much to the facilitator for such an amazing time here. Like, I learned new things in such a short time. So we'll continue with our lectures in the coming weeks. So stay tuned in the group chat to get further information. Thank you and good night, everyone. So I'll be ending.